very inappropriately brought my coffee up here. Good morning. Thank you all for joining us today. My name is Dr. Rachna Shroff. I am the Chief of Hematology Oncology here at the University of Arizona Cancer Center and the Associate Director of Clinical Research for our cancer center. But most importantly, I'm a GI medical oncologist who has been involved with the Cholangiocarcinoma Foundation for probably the entirety of my career. And so it is a very huge privilege and honor for me to be standing up here today and to be welcoming you all to the first, hopefully and not the last, University of Arizona Cancer Center and Cholangiocarcinoma Foundation partnered Cholangiocarcinoma Regional Symposium. So I'm just going to give a really high-level overview. A lot of you have probably heard me speak on cholangiocarcinoma. I'm not doing that today. I get to have the fun job. And so I just want to kind of level set a little bit about who we are here at the Cancer Center, because we take a lot of pride in the role that we play in Arizona, Southern Arizona, and the entirety of the state. The University of Arizona Cancer Center is actually one of the first cancer centers to receive designation from the National Cancer Institute. It was founded in 1976, it was designated in 1978, and has been continuously designated since then. There's a kind of second tier of designation from the National Cancer Institute that involves what's called comprehensive status. And we achieved comprehensive status in 1990, with our most recent renewal being incredibly successful in 2022. And as you can see, we've had a lot of really eminent leaders. This institution was founded by Sid Salmon, who is of incredible fame in the multiple myeloma space. But you guys might also see a picture of Dan von Hoff, who is the man behind a lot of work in GI malignancies and drugs that we now use in cholangiocarcinoma. I am standing up here in my role as a GI medical oncologist, but our cancer center, Dr. Sweezy, was our prior director. She moved on to a wonderful opportunity in Nebraska, and so our cancer center is currently in an interim leadership position with 3 people. I have the privilege of serving with 2 incredible women. Dr. Juanita Merchant is our interim director. She also serves as our associate director of basic science, and Dr. Clara Curiel is our other interim director. And neither of them could be here. They're both traveling, so they send their warm regards and welcome as well. Just a little bit about what this place is and what we represent and what we do. So for the National Cancer Institute's sake, we have what we call catchment area, an area that we really focus on in providing services to patients. And our catchment area is the 5 southern counties of Arizona. That includes this county that Tucson sits in, which is Pima, but includes 4 other counties. And as you can see, a lot of them are border counties. And 90% of the patients that are served in our cancer center come from these 5 southern counties, with a population almost close to 2 million in that area. But what I think is really important is we take the patients that we serve really seriously here. And so the populations in our catchment include 38% Hispanic, 22 American Indian tribes, and 7 tribes are in the state, but 7 tribes specifically within our catchment, with 2.4% of our patients being Native Americans. And obviously, we're in the middle of snowbird season. We have a very significant percentage of patients who are elderly, which of course is very relevant to the cancer world. So you're going to hear from a lot of these speakers today. What has been tremendous in the last few years is to watch our program in GI oncology and specifically in cholangiocarcinoma grow. We have a fantastic, strong team in terms of multidisciplinary excellence. Dr. Ryle, who you'll be hearing from, is really kind of the backbone and spine of our cholangiocarcinoma and hepatobiliary and pancreas program as a whole. She is our division chief of surgical oncology and was here before I was here and had already just garnered so much momentum in this space. And then everybody else, like I said, you will hear from today, but involves interventional radiology, medical oncology, surgical oncology, transplant, gastroenterology, radiation oncology. We really have a wonderful team of people here, and I could not be more privileged to be part of it. So to that end, I think it's really cool to think about the things that the Cancer Center has done in partnership with the foundation. So while this symposium represents an official event of partnership, this is just some of the things that investigators here at the University of Arizona Cancer Center have been involved in. So working with getting drugs FDA approved, including some of the FGFR inhibitors and IDH inhibitors that we know and love and are so grateful for. Studies that are going to probably lead to some more FDA approvals, including zanidatamab and tucatinib trastuzumab. And then the Brightline 2 trial, which is about to open here, but of course is going to be very relevant to patients with MDM2 amplifications. And we've partnered together in other ways. We had the privilege of working from the University of Arizona Cancer Center investigators, had the privilege of working with the foundation on a really important white paper about the role of crossovers and study design and what that really means for patients and access to drugs. And SWOG 1815 was a really important study here at the Cancer Center, and the foundation was instrumental in bringing attention to it and getting patients on that study, which was really important. And there's a lot of the co-investigators from 1815 here today that you'll be hearing from. And we've really made it a focus here. So since 2018, we have increased the number of trials that we have. We really want to make sure that we have trials for all of our cholangiocarcinoma patients, especially in this wonderful world of targeted therapy and precision oncology, making sure that we capture every single patient and offer opportunities to them. And this is, I'm not going to go through this, but this is just a list since 2018 of the studies that have opened, closed, been concluded, and are currently open in our GI portfolio, which we're really proud of. And so with that, I just want to thank our external speakers. We have an incredible team internally, but we also know, I know how much travel is involved in this job, and so it's a lot for our external speakers to have their daughter perform in a musical theater performance and fly in late at night and run home to a mother-in-law's birthday. So I'm so grateful to all of you all. This cholangiocarcinoma community is an incredible one. It's anchored by Stacy and Melinda, but I'm very grateful to all of you for coming. And I will tell you, you'll hear me do this basically as I introduce every speaker. The best part of this community are these people. They are incredible people. They're wonderful humans. And we have so many great memories that we have built together. And so it means so much to me that you all are here and helping us spearhead this regional symposium together. And with that, I thank you all for coming, and I'm very delighted to introduce our first speaker. So, I don't think she needs much introduction. If we had an audience response system here and we asked how many of you have felt the impact of Stacy Lindsay in your life, I think 99.9% would raise their hand. Stacy Lindsay's brother, Mark Clements, was diagnosed in 2005 and passed away from cholangiocarcinoma in 2007. She has been an incredible advocate for her brother. At the time, there was not much out there. They felt lost, they felt hopeless, they felt desperate. And so Mark gave her the baton and said, this is the one thing you need to do. So she is the president and founder of the Cholangiocarcinoma Foundation, and it was born, I'm wearing my 15-year anniversary necklace, but it was born, that's been more than 15 years now, and she literally took it from the ground up. And she's a founding member, served on the board since its inception. She lives in Salt Lake City, but has gone literally all over the world, bringing attention to and advocating for this disease. And there is probably nobody else in this room that has had more of an impact for our patients, for the community, for the researchers, for the physicians, and for every single person that cares about cholangiocarcinoma. And so it is my privilege to welcome her. And I made her cry. I'm so sorry, Stacey.
Rashna. Thank you for being here today. It's been such a pleasure to meet so many of you personally and to meet a 27-year survivor and to meet a recent transplant patient and to meet recent patients. And thank you for being here. We have an annual conference every year in Salt Lake City where all of the scientists and specialists from across the world gather, and patients are invited to that. We know that the patients don't always feel well enough to join us there. So it's important that we do these regional symposiums. We want the institutions to get the recognition that they deserve for their involvement in this disease, but also to go where the patients are so that we can perhaps reach patients that can't reach us. So thank you for being here. As Rashna said, my brother was diagnosed at 38 years old. And his fourth child was born just 2 months after he was diagnosed. So he and his wife, Marianne, were desperate for help. And he had 3 sisters, and we were desperate to help him. And we just could not, 17 years ago, find anything for him. So, I'm sorry, Rashna. So, I'm emotional anyway, but on his last treatment, I was with him and we were coming home, and he expressed to me, we were out of options, and he said, Stacy, what are you going to do with all the research you've done? And I said, I don't know. We'd started a discussion board, and we were talking with other patients. We were trying to see if anyone had any options, if anything was working for anyone. And he said, I think we need to start a foundation. I said, okay. And so that was the beginning. It was that simple. I really was just thinking about him and his family and our family, but he was thinking about you, all of those who would come later. So, okay. So the foundation we focus on 2 pillars. One is the patients and the caregivers, and the other are research and breakthroughs. And I'm just going to take you through a few of those things, and then Melinda can tell you a little bit more about her story and some of those specifics. But if you'd like to see our strategic plan, you can see the QR code there, and you're welcome to click that and take a look. So I just wanted to talk about the foundation. We are virtual and have been since the very beginning. And so it is an international group, and you can see the top 10 countries of participation on the website there. We get, I don't work for you. Thank you so much. Thank you. But there's a lot of traffic on the website, and it continues to increase. We continue to do more internationally. And we know that no one institution, no one investigator, no one scientist is going to solve this problem. It's going to be a global collaboration, and we're really working hard to make that happen. So one of the things that's going to be happening this year is a website redesign and refresh, and we're excited about that because it's going to be so much more easier to get information on your mobile phone, which is what most people are doing. When you're 17 years old, you do have to update occasionally, so we're working on that. And I want to take you through just a couple of the bigger programs. You can see the newly diagnosed portal came into being a little more than a year ago, almost 2 years ago, where we wanted the newly diagnosed patients not to have to look around on the website, but to be able to go into one portal and find exactly what they needed very quickly. So, Melinda, could you get in my bag, the top, and bring me my glasses so I can see? Thank you. But more than 1,900 unique patients go into that portal every month. Now, we know a lot of those are caregivers and family and friends, but of those, we deliver, thank you, for free for patients who sign up and fill out a small survey so we know where they're coming from. We send them a free care kit that has just some items to help them with their newly diagnosed status. And then you can see the survey information down there below. Most of them are newly connected who fill out the survey. Most of them are patients. And then you can see their status, intrahepatic, perihilar, or distal there. So just a little bit more about the newly diagnosed portal. And this is just information that might be of interest to you. We work with a health data company called Komodo, and we can see, now they work with claims. So we can see from their data, these are just insured patients, that they are seeing 244 newly diagnosed claims come in weekly, okay? We see 388 patients or people coming into that newly diagnosed portal weekly. And we're sending out about 23 care kits. So we've got a gap there. They're coming in, but they're not necessarily right. We're not capturing all those, and so we want to do that. So how are we closing that gap? We're Facebook ads and social media. We do monthly webinars for just for the newly diagnosed patients. That we're excited to be able to do that every month. Is have a webinar where the newly diagnosed patients can come on and get all the information and talk with Melinda and the other navigators and get the information that they need. We attend, national conferences and cancer coalitions. We also get from Komodo the provider information for those newly diagnosed patients, and we send those providers information. Many of them are community providers, so they don't see a lot of cholangiocarcinoma. So they get an email from us that says, hey, we see that you saw a new cholangio patient. Would you connect them to us? We have some services that might be of help. So a lot of things we're doing to reach out to those patients and try and help them. And here you can see the program started in August of 2021. We've distributed over 2,000 of those care kits. And here are just some of the interesting survey results from the patients who have filled those out, that 47% of the patients were not encouraged to get a second opinion. 21% of the patients were provided with helpful education materials. Just only 21% felt like they got helpful information, so 1/5. 70% of patients were provided enough information to understand their treatment plan. That's great news. But only 13% of patients were advised that clinical trials could be an option for them. And if there are several specialists here, and we hope that's shocking to everyone, because if you're a patient of cholangiocarcinoma, most likely your treatment pathway is going to include a clinical trial. And then 48% of patients were informed about biomarker testing. Now that has gone up every single year. We've done a lot of education on biomarker testing, which is so important for these patients. We have a free nutrition resource. This is one of the top 3 questions that we are asked when patients contact the foundation. What should they be eating? How should they be exercising? Should they change their lifestyle? This was produced in partnership with the Oncology Dietitian Practice Group. This is a fantastic and free resource to patients. And again, you can see the QR code, or you can contact us, and we're happy to get that to you. The other free resource that we have for patients is a free 100 questions and answers book. And this is all about cholangiocarcinoma, includes gallbladder and bile duct cancers. And this has been a great resource. It's very, very simple to read. It's written for a patient who does not have a medical background, so it just gives you a lot of information that will be helpful. Again, it's free. We're doing a lot of DEI outreach. We're doing that through translating resources and webinars. A lot of that will be on the new website when it comes up. We have a Spanish-speaking patient support group. Lourdes speaks Spanish, and she runs that. We have a Vietnam veterans group. We have a bereaved group. We have a current caregivers group. We have a patient group, and some of those support groups are averaging about 40 to 50 patients every month that they're running, or every other week, right? Every other week, and so they're getting a lot of support and help and guidance there. I think this is interesting. This is our patient registry that runs on the Citizen platform. But if you look of those who are filling out the information on the patient registry, you can see that the DEI is pretty good on that. 12% Black, 6% Asian, 12% Hispanic is pretty. Those are pretty good numbers. So we're hoping to increase that as well. So as we continue to reach out. Just want to show you some of the international groups that we are working with and collaborating with across the world. And many of these are very small. The Russian group, the Canadian group is big and growing and really coming on strong. They just got a $7 million grant specific to cholangiocarcinoma. And we help them do that. We're very proud of that, to get these groups running up. We know that these patients will do best if they have help within the system in which they're being seen. They need help navigating those systems, and they're different in every country. So we're really happy to help these groups, to give them access to all the information they need to help them. They can take anything off our website that they want and translate it into languages that are appropriate. We meet with a Japanese group that we've helped set up regularly, and several of these groups, and we're working on a lot of international opportunities for patients. As I talked about earlier, the patient education webinar series is bi-monthly. We've had more than 75 of these webinars, and they average about 500 views on YouTube. And usually, depending, we'll have between 50 and over 100 patients sometimes on these webinars. And you can see the one, there was one out of Harvard by, Dr. Bullock. And it's had over 2,000 views on YouTube. So these are really well-watched videos, and they're on all different things. They're on latest clinical trials. They're on nutrition. They're on all kinds of issues and programs that the patients are interested in. So they've been very successful. A lot of multidisciplinary clinical updates as well. I wanted to just share with you a little bit more about CholangioConnect. Dave Fleischer spoke about it earlier. This is a program that started with a caregiver whose wife was quite young. They had I think he was under their one son, and she was diagnosed, she passed away, and he desperately needed someone to talk to, who also had young children, because he needed some help talking with his son. And he could not find anything on any of the more national kind of connection programs. And so he put together this structure and came to us and said, hey, could we start this program? And so we did, and we're so grateful to him for helping us put this together. And currently we've matched almost 1,100 patients, and there are several in this room who have been mentors. You can understand how meaningful it is to be able to just talk with someone. The mentors are not giving medical advice, but also the nurses and the doctors don't always have a half an hour or an hour of time to just talk through some of the emotional issues that come up with cancer. So significant growth, of course, equals significant need. And so for those of you who are physicians, if you have long-term survivors, or even those who are recently diagnosed who would like to interact with others, they can be a mentee or they can be a mentor. And it really is a meaningful program and has been such a success for so many. This is Grace, who was a mentee, and then as she became a long-term survivor, is a mentor now, and it has been just a wonderful experience for her. Another thing I want to talk about was the biliary emergency information card. This was launched in 2017, and this is contact information for your patient's doctor. And this is, when you have a biliary stent or a drain, if you've had some sort of procedure, there's always a risk of ascending cholangitis, and that's an infection, and it can be difficult to treat, especially if it flares up on the weekend or when you're away from home. And the biliary emergency information card is something that you go in, you fill out primarily. It's kind of like a cardiac card, if you've heard of those before. You just give it to the doctor. It's approved by our Scientific and Medical Advisory Board. It tells the treating physician in the emergency room or wherever you are exactly what's going on and how they can help you. So it's important for patients to have that available. And again, there's a QR code there that you can follow, or you can find it on our website. Just quickly, I wanted to talk about the International Cholangiocarcinoma Research Network. Many of you know Dr. Borad, and this was Dr. Borad's idea at, I think, our second conference. He said we need to start a research network. We really need to bring the scientists and the physicians together and really start working at this problem. And so we did that, and currently there are 333 ICRN members, 157 participating institutions in 27 countries. And really this is about, again, the global collaboration on this disease, which is what it's going to take for us to move things forward. And we've had a lot of success there, so we're excited about some things that are coming up that I'll talk about. Anyway, if anyone's interested, there's another QR code there. We'd love to have you join, and there's a lot of data and publishing, data and publishing opportunities, a lot of speaking, leadership opportunities, collaboration, mentoring, all kinds of things for the young investigators and the senior investigators to participate in. We also have the ICRN host translational webinars. These have been really fantastic, and we have an upcoming one in January on targeting KRAS. Really has been great. We have a new chief medical officer, Juan Ballet, who is heading this up. He's doing really amazing work, and we're excited to see what's coming. In May of 2022, we had C2T2, which is the Cure Cholangiocarcinoma think tank, and this was a donor who wanted to do something really significant. And so our Scientific and Medical Advisory Board came together and said, this is what would be really helpful to us, is to have a small meeting where we focus on early detection. We've never done that in this space before, and we brought in outside specialists who had success in their different cancer spaces to help educate us. And also we worked on precision therapeutics, and from that have come some really significant things. And we did over $700,000 of donor funding to help support that. And I'm going to show you this next slide and tell you a little bit about it. But this is the master protocol trial, and I was talking with some of you earlier about this. And this is one of the most exciting things, I think, that has happened since I've been working in this field. And this is all of the investigators at the bigger institutions and even the smaller institutions working together on a master protocol trial. And what that means, if you're not familiar, means that the foundation has put together a platform with GCARD, this Global Coalition for Adaptive Research. And it's a kind of almost like a plug and play. So instead of and you all know we have these small mutations and aberrations, and drug companies are going after all these things, and they usually work with one or two institutions. And when you're looking at a rare cancer with rare mutations, there's this very small population. So imagine if you work with one institution or two institutions, it takes a long time to accrue patients and get answers to those questions if things are working or if they aren't. But when we all work together collaboratively, all the major institutions, and they just plug right in and we get this drug, and then, oh, there's one here, and there's one here, and there's one here, and there's one here, we can quickly accrue and get answers to our questions. It's much cheaper for pharmaceutical companies to bring small ideas to the table there and have patients get access. And then when we find a good answer, when we look at the data and we're like, this looks good, we can roll that right in, and then we can move to bigger trials. And so this is very exciting, and the first time that it's been done in this space, so we're really excited. And going back to the C2T2, down below on the bottom, you see this is the phase 1 engine, and phase 1 is where we're really looking at, how the drugs work within the body, and then we can move to bigger trials. Well, that comes from the C2T2. That comes from MGH, so the Harvard system working with the Broad that had this previous funding here from the C2T2 meeting. They're screening all these drugs and screening all kinds of different things and combinations and different things, and then those can feed right into that phase 1. So this is really, really exciting time to see things moving forward in a meaningful way and to see this whole community come together for you, for the patients. We do have a research fellowship program. We've done 49 research fellowships and funded about $2.5 million. We're just about, this next year, we'll give out another 10 fellowship programs. This has been really exciting to see so many of these research fellows in the last 10 years become the senior leadership in this space and really doing meaningful things. These are some of the institutions that we have funded specific to cholangiocarcinoma research and who are always working together on these grants. And then we have these really rich data partnerships, which we're really excited about, Komodo being one of them. And then also is Citizen, which is our patient registry. Really important if you're a patient that you participate in this. This is the way that you can help us advance the research. And we need it for so many significant things, but especially for FDA approvals. This is really important. And one of the things there are several things that we're trying to do, but some of the significant things we're trying to do with this data is build the richest, continually updated database of cholangiocarcinoma natural history data. And that's what Citizen is helping us do. And then this is the ability for pharma to utilize this data set when they're taking drugs to the FDA for approval. It's a really great publication environment for academia. And then FDA, we just had a meeting with FDA on Monday talking specifically about this data and how it will be used, because really what we want to do is create a synthetic control arm from the data that can then really help us move these drugs forward in a meaningful way. So I wanted to invite you, for those of you who've never attended the annual conference in Salt Lake City, it's going to be April the 17th through the 19th. And this is going to be a very unique conference. Patients are always invited. Patients and caregivers can participate. But this year we're going to have 2 hours with the regulatory bodies. We have regulators from FDA coming, regulators from the EMA, regulators from the PDMA in Japan, regulators from China, regulators from Canada, and hopefully South Korea. And they're going to be doing a 2-hour session there working with the investigators on how we can, there are some regulatory things that are not helpful to us, and we're trying to work through that and really make this streamline some of these processes, but really work with these regulators. They want to help too, but they need to have the information from the investigators, and they want to hear patient input. So this is going to be a really exciting meeting. And then the other unique thing about this conference is that we're also going to have a basic science track. And so Sumera Elias from Mayo Clinic and Daniela Sia are going to be running that. And that's going to be on Wednesday. It's going to be parallel to the patient day. So we're really excited to give the basic science scientists the opportunity to really dive deeper together when they're at the annual conference. So we hope you'll join us there. It's really exciting, even if you don't understand one thing about the science or even the clinical and translational pieces. It's really exciting to see the top specialists in the world come together and really be working on these problems together. It's really a hopeful thing. And you inspire a lot of hope in these investigators and scientists as well. So important that the patients be there. And then the last thing that I wanted to share with you is that in 2025, we are going to be having another very unique conference. It will be the annual conference. It will also be supported by ENSCA, which is the European Cholangiocarcinoma Research Network, and we do a lot of collaborative work with them. So it's going to be ICRN, our research network, and the European network coming together, and we're going to be doing a research priorities consensus conference. This is going to be really exciting because all of the specialists are going to be there. The work has already started for this conference, and working groups are in the works for what are the research priorities, what needs to be funded if we're going to really make an impact in this disease. And so that's in pathology. What are the gaps and what kind of research, what needs to be done there in all these different specialties in surgery, in radiation oncology. We're all going to be working together, and then they will bring what they've come up with for the year to that conference, and then we'll be working on that together until so there'll be a big publication that will come out afterwards. It's going to be pretty exciting to work on this, and we're really, really happy to be moving that forward as well. So if you have any questions, please feel free to contact me. I'm really happy to talk with you if you need it, or to direct you to Melinda or her team if they can help you with specific things. We're this organization, and we're not about growth and getting big and we're about helping the patients. And we are only here to help you. So please, if we can assist you in any way, let us know. And for the physicians that are here, please send your patients to the foundation so that we can help them. There are so many things. We can help them with all kinds of resources. Melinda and her team are on the phone all day long helping patients and just listening to them. Sometimes they just need to talk, and we know that you don't always have the time to do that, but we do. And that's why we're here, so we're really happy to help. So thank you.
Thank you, Stacy. I have the privilege of being involved in a lot of the different things that Stacy just mentioned, but when she puts it all together into a slide deck, it's just incredible, the amount of work that is happening. So next, I have the privilege of introducing Dr. Aaron Scott. He is one of our GI medical oncologists here at the University of Arizona Cancer Center. He is originally from Tucson and did his college and med school here at the University of Arizona, and then went away to Colorado, but we luckily plucked him back and brought him home. He's been on our faculty since 2016 and is an incredible clinical and translational investigator. I will tell you personally, I have seen him grow in the last 5 years that I've been here into just a tremendous, not only investigator, but just one of the most compassionate physicians I know, fantastic leader. He leads one of our cancer center programs, the Clinical and Translational Oncology program, and he now runs our GI cancer program. And so it is my privilege to introduce Dr. Scott.
Thank you, Dr. Schroff. Wow. I prepared to give some educational input and understanding into the first-line setting for treatment of cholangiocarcinoma. I was not prepared with tissues. That was an amazing intro, and it just really speaks to the heart of foundations like this to help patients. Such an honor to be a part of this, and I'm very excited to be here, so thank you. All right, so I'm going to talk to you a little bit about the current landscape for advanced cholangiocarcinoma. This will really be focused on frontline setting for unresectable, metastatic, locally advanced cancers. And I'm really going to try to speak in terms that are hopefully understandable. Some of you know this data very well. Others of you might not. So I'm going to do my best in 20 minutes to kind of go over some things that I think are truly exceptional and why cholangiocarcinoma seems to now be the envy from a research perspective compared to a lot of other GI cancer types. I treat mainly colorectal. That's where my emphasis is on research, but it's just a tremendous improvement over the last several years in our therapies for BTCs. So I want to orient us to what we're talking about today from a scientific perspective. Biliary tract cancers are not just one cancer. You're going to hear terms like biliary tract cancers, BTCs, cholangiocarcinomas. What are they? What are they comprised of? And I think first and foremost, we start with anatomical descriptions. This is how we categorize our biliary tract cancers. For most part, they're adenocarcinomas. These are the most aggressive types of cancers that we treat in the GI tract. In fact, unfortunately, they're associated with poor prognosis. The median overall survival as a collective is about 12 months. And in large part, that's because we have historically limited treatment options. They're broken down into really three main subtypes: intrahepatic cholangiocarcinoma, extrahepatic cholangiocarcinoma, which really just means the tumor originates in the biliary tract, which is kind of like a tree in the liver, starts small, goes down to a trunk in the main tract, the biliary tract, and those extrahepatic cholangiocarcinomas arise outside of the liver. And then we have gallbladder cancers. So we have three main subtypes that we categorize BTCs. So why should we be focused on treating BTC? Well, I think in large part it's already been explained. These have poor prognoses, and I think it's pertinent to mention the incidence is rising. Over the past 20 years or so, it's been noted that the incidence is increasing among some of the highest, especially in GI cancers, and unfortunately in some of the youngest patients. So the age group that sees the highest rate of increased incidence is those between 20 and 40 years of age. And it speaks volumes into, when we hear stories of young patients, young families suffering from this condition, it just really speaks to how important it is that we focus on BTCs. So as I mentioned, this is a disease with a poor prognosis. Historically, we've treated this as one disease, and so we've quite frankly been lumpers. But now, with the advent of both a better understanding of molecular subtypes, how we can use targeted therapies, we are now into the splitter narrative. And in large part, again, this is because we have molecular analysis. And this is a very long list of the different subtypes. Anatomical subtypes have different molecular characteristics. But this is so much to say that we have made headway with some molecular profiling and targeted therapies, such as IDH inhibitors and FGFR fusion inhibitors, etc. But you can see there's a long list of molecular characteristics that are associated with BTCs. And for good news, we've made some headway on targeted therapies. I think in better news, we have a lot of other targets to focus on. We're entering into the era of precision medicine and oncology, and this speaks volumes for BTC's future in a positive light. Historically, we've treated BTCs with chemotherapy. Gemcitabine cisplatin came online approximately 10 years ago, 2010, after ABC02 clinical trial showed that the combination of gemcitabine plus cisplatin outperformed single-agent gemcitabine. And you can see those survival curve, the Kaplan-Meier, so the y-axis being the percent alive, patients that were alive, and then the x-axis being time. And you can see that separation of the curve very nicely. However, when we looked at immunotherapy, when it first came online approximately 7 or 8 years ago, we see that single-agent immunotherapy really was very modest. It really didn't show much improvement in survival or response rates. So how do we improve immunotherapy's response? Well, over time we've learned that combining different therapies can induce a change in the tumor. We see increase in the amount of immune cells that can kill cancer and a decrease in the amount of immune cells that support cancer. There are technical terms like cytotoxic T lymphocytes, CD8 positive T lymphocytes, and T regulatory cells, but we really want to emphasize the point that chemotherapies such as gemcitabine, cisplatins can induce this change. So if we combine chemotherapy with immunotherapy, maybe we'll actually have an improved response. We take that monotherapy, the very modest response with single-agent immunotherapy, and change that. So on comes along TOPAZ-1. This is a phase 3 study, randomized, double-blind, placebo-controlled trial that was done globally. It randomized patients in a 1-to-1 fashion, patients with advanced, unresectable, or locally advanced BTCs, a collection of all the different 3 subtypes. And they randomized between durvalumab plus chemo, gemcitabine plus cisplatin, versus gemcitabine plus cisplatin plus placebo. They treated patients up to 8 cycles, and this was followed with maintenance therapy, either single-agent durvalumab, which is an immunotherapy, versus placebo every 4 weeks. The demographics were relatively similar across the 2 groups, and the reason why we show this is because it's very important that when we run clinical trials, we balance both arms so that we make sure we're studying the same patient population. As we talked about already, there are different molecular subtypes. Region matters, right? So Asian population versus other, because Asians generally have a little bit of different tumor profile in response to treatment. And so it's very important that when we're assessing trials like this, that we're looking at this baseline characteristic, the demographics, okay? So fortunately, in this trial, very well balanced. And this is what we saw. So this was the primary endpoint for TOPAZ-1. This is the updated overall survival analysis, and for those that may not know what the overall survival term means, it just means death from any cause. So over time, we measure death from any cause on these trials. And again, the y-axis showing the percent of patients alive, and the x-axis showing time. You can see at each time point measured, 12-month, 18-month, and 24-month, those curves are separated. When you're a trainee in oncology, we always say if you're sitting in the back row and you can put a finger between the 2 curves, that's a positive trial. Well, you could pretty much do that here. So this is a very, very good result. In terms of how this really came out, everybody was very excited. We still are. And for that reason, it's become one of our first-line treatments. The 24-month overall survival was 24% versus 11.5%. Again, almost more than doubling of the overall survival, and at 24 months in this disease type, that's pretty impressive. Going back to subgroup analysis, so again, I mentioned molecular subtypes, anatomical site, and region and race are important factors that we look at for cholangiocarcinoma, and you can see that across pretty much all different subgroups, this was a positive study, which we, again, going from lumper to splitter and back to lumper, it's always nice to see a treatment that can be applied to everyone with that disease. And when we look at the mutational perspective, we see that although this was a small subset of patients, unfortunately we don't have all the patients on the trial don't have the molecular analysis needed to make, I think, very strong conclusions. Again, we can see that regardless of the mutation subtype, we see that there was a response in favor of durvalumab. So if you go to the left of the curve, it's in favor of durvalumab and the cisplatin gemcitabine. If you go to the right of the curve, that would be in favor of just gemcitabine plus cisplatin alone, and you can see the difference there. As same thing for progression-free survival. You can see that durvalumab plus the chemo outperformed placebo plus gemcitabine plus cisplatin. The progression-free survival difference, the terminology is that you're measuring whether a patient cancer is progressing or growing or not. When we look at response rate, which is another important endpoint, especially for those patients that are locally advanced, where we're thinking that we can maybe get them to a more aggressive treatment approach. Again, I have 20 minutes to talk to you about what would take probably an entire day in discussing all the options. But if you have a locally advanced cholangiocarcinoma, oftentimes the tumor board and your doctors are going to be talking about how we can be more aggressive if we can get a good response. And so you can see that a large portion of patients had a partial response on this regimen. Durvalumab plus Gem/Cis had a partial response of 24.6%, and a total objective response, meaning complete response where no evidence of cancer left on the scan, plus partial response where some cancers left on the scan, was 26.7%. This is compared to 18.7% with chemo alone. So very impressive difference between response rates. And when we look at adverse events, which I think is as important as whether it keeps people alive and they're getting a response, because again, quality of life matters. Patient-reported outcomes are always essential when we're interpreting data like this. We see that adverse event profile is relatively similar across the two groups, which in my opinion is fantastic. We don't expect that adding more to a regimen ever really means that you're going to have the same or less adverse events, but in this case it's pretty similar, so that's very good news. Okay, so that was TOPAZ-1. That came out first in terms of immunotherapy combination first-line trials. We're going to go into KEYNOTE-966 study now. It's a very similar patient population. Okay, again, we're looking at unresectable, locally advanced, or metastatic cholangiocarcinomas, all three disease sites. And in this case, we're combining pembrolizumab, gemcitabine, and cisplatin compared to placebo plus gemcitabine plus cisplatin. So the same chemotherapy backbone, it's just a different immunotherapy. They're very similar in mechanism of action, but in this case, it's pembrolizumab. So I will note one difference on the study design from KEYNOTE compared to TOPAZ is that KEYNOTE allowed gemcitabine to be a part of the maintenance therapy. And we'll get more into this in the future, but it wasn't just placebo alone for the maintenance therapies. Again, the baseline characteristics were very similar across the board. The percentages were very similar to TOPAZ as well. And we see that the overall survival was a positive finding. Very similar to TOPAZ, the 24-month rate overall survival was 25% in the investigational arm, the pembrolizumab plus Gem/Cis, compared to 18% in the placebo plus Gem/Cis arm. And when we look at the two trials compared together, I think they're relatively similar. We, again, pay attention to region because our Asian counterparts seem to respond differently and oftentimes better with immunotherapies. And the intrahepatic diagnosis represented the majority of patients on this trial. From an MSI high perspective, so why do we put that in there? Well, we know that if you have microsatellite unstable tumors, which again, don't have time to go into what all that means, but if you have an MSI high tumor type, you generally respond better to immunotherapy. So it's always important to have those arms balanced. And across TOPAZ and KEYNOTE-966, we see that they're very balanced. All right, so let's compare the overall survival at final analysis. We can see, again, the overall survival rates for the investigational arm were very similar, basically 25% in both studies at 24 months. But there is a difference in the control arm, and again, the control being the chemotherapy alone, but in TOPAZ, on the bottom right, you can see it was 10%, and in KEYNOTE-966, it was 18%. So what may account for that? As I mentioned, the gemcitabine was allowed to be used versus placebo alone in the TOPAZ, so that's probably a part of the reason. And across response rates, you can see that the investigator-assessed response rate in TOPAZ was very similar to the central review response rate in the KEYNOTE-966, both in the upper 20%. And again, the difference in the control arm in KEYNOTE-966 was 28% versus 18%. And I suspect that there might be some molecular differences in that group, as well as the single-agent gemcitabine being allowed to be used as maintenance therapy. And the adverse event summary for KEYNOTE-966 was also very similar in terms of pembro plus chemo versus chemo. No additional side effects noted in terms of significance. and it was very similar to the rates seen in TOPAZ. Moving on from immunotherapy combinations, we have a chemo alone study, the SWOG 1815, that's been mentioned already this morning. I think many of you probably know about this. This was a trial that was led by Dr. Schroff. It was a study that primarily included US patients, and it was a first-line advanced cholangiocarcinoma and gallbladder cancer, very similar to the patient populations in TOPAZ and Keynote. This study combined gemcitabine plus cisplatin plus nab-paclitaxel versus the historic control gemcitabine plus cisplatin. The baseline characteristics very similar across the board based on race and site of disease, and locally advanced versus metastatic. This is a survival curve, all right? So the overall survival was not positive in favor of the GAP regimen, that being the triplet chemotherapy, when compared to just gemcitabine plus cisplatin. Numerically, it was better, 14 months versus 12.7, but statistically significant, no. And you can see those curves overlap. However, when you break it down by disease subtype, you can see that the gallbladder adenocarcinomas did much better with GAP regimen versus this gem-cis doublet therapy. And we look at the overall survival by disease stage, meaning is this locally advanced versus metastatic. You can also see that the locally advanced patients fared much better versus the metastatic. And this, again, leads to the question of, can we get patients to a resection or more aggressive treatment if they just have locally advanced disease versus metastatic? So in summary, we have now 2 IO combination treatments based on TOPAZ and Keynote 966. Are they interchangeable? Well, I'd say the data is pretty compelling that they may be. I think the big question is whether or not the maintenance therapy should be single-agent immunotherapy, but if you're going on Keynote 966, whether you include gemcitabine as well. And I think these issues need to be teased out more in future trials. I also think that the Keynote 966 biorepository, so the specimens, the samples, the biopsies, the blood that were taken from patients that went on this trial have yet to be analyzed. And I think this is really going to provide some insight into whether there are certain groups of patients with certain molecular subtypes that really respond well to this regimen compared to all comers. So I also want to say that the GAP regimen may be useful in certain settings. Gallbladder cancers, especially locally advanced gallbladder cancers, showed a mark that there might be some signal there to further investigate, and I believe there's an ongoing trial now looking at this disease group. So thank you very much. That's my slides.
Thank you so much, Dr. Scott. It's really exciting that we now have enough going on in the front line or in the newly diagnosed space for us to have kind of a very comprehensive overview. And for those of us who've been waiting to get into the immunotherapy game, it's really a wonderful space to be in at this point. I now have the privilege of introducing Kelly Roan. She graduated from Texas Women's University in 1999 and went on to get her Doctor of Nursing Practice from Arizona State in 2014. She currently serves as an advanced practice nurse in the GI oncology team at Mayo Clinic in Phoenix, Arizona, with Dr. Borad and a number of other oncologists that I'm sure we all know and appreciate and love. She initially actually worked in the Texas space in Dallas and then with Texas Oncology, and then left for a little bit to work in the cardiovascular intensive care unit, but recognized that she missed working with oncology patients. And so now back in oncology at Mayo, Arizona, she actually has the chance to really see and take care of patients like you and make such an impact, because our APPs are really our lifelines. Please welcome her.
All right, so the technology is the worst part here. So I am very glad to be here today, and what I will be talking about is approaches to hyperbilirubinemia. Is it a therapy side effect, or is it an obstruction? So as many of us know that when patients are first diagnosed with their biliary cancer, they will develop in a very similar way. They develop jaundice, dark urine, they get right upper quadrant pain, they get itchy. They have all these things that are going on. They've been losing weight, and it turns out it's not really their diet that they're maintaining, it's just because there's something amiss. So they will often present to an emergency room where they have an ultrasound to see if they have a gallbladder or a gallstone or maybe something that is going wrong with their gallbladder. They'll have a CT or an MRI to kind of figure out what's happening. Usually the imaging will show that there is a stricture in the biliary tree, and then they will proceed on to have a procedure to place a stent, if possible, into where the stricture is occurring, or if that's not possible, sometimes they will need what's called a percutaneous drain, where they have a drain that is draining the bile externally. Sometimes patients actually get both. So where the cancer is located, as has been discussed, is a very important factor in how the cancer presents or how the cancer is treated. So where the cholangiocarcinoma develops will often cause different changes that makes the patient present in a different way. So most of those who have a biliary obstruction will have a perihilar involvement. There is a classification that is used to determine exactly where their obstruction occurs or where the cancer occurs. They may need a plastic or a metal stent in order to open up that pathway and cause their lab values to return to normal. And as mentioned, the drain may be one of the things that they need to have. Cholangitis is one of the side effects of the manipulation of the biliary tree. If there's a plastic or a metal stent or a drain, that is something that is not normal, and the body says that doesn't belong. The bile is very thick, bacteria love it, and patients can often develop cholangitis, and you can become quite ill. So we're going to talk about a patient that I saw. She is a 54-year-old woman. She had a past medical history of endometrial cancer that had been diagnosed and treated in 2009. Because of a large family history of a variety of cancers, there was some genetic testing done, and she was found to have a Lynch syndrome. And she was in a surveillance. She was actually being seen at a oncologist's office because of her endometrial cancer, where they were kind of doing some surveillance related to her Lynch syndrome. But in May of 2020, she presented to the emergency department with jaundice that had been worsening for 2 to 3 weeks. And when she started getting the abdominal pain, that's when she went to the emergency room. Her bilirubin was 11.7. Her direct bilirubin was 8.6. All of her liver function was elevated, and her lipase was almost 14,000. She had a CT scan that showed she had an intrahepatic biliary duct, but no real mass. So some of the patients in here can probably recognize this story. So she had the ERCP. She had 2 biliary and 1 pancreatic stent placed. But because her cancer was localized, she had no metastatic spread, she was recommended to start the process for a liver transplant in order to be cured of her cancer. When patients go through that process, they find that they meet a lot of new people, including people like me, and they start oral chemotherapy, and then they have radiation to the area where their cancer is. That process lasts 3 weeks. Usually people do okay. It's not the most fun you've ever had, but they do okay. This patient, however, started having outrageous difficulties with her oral chemotherapy almost from the start. And so she was admitted to the hospital, had significant mouth sores, crazy hand and foot syndrome, diarrhea. All of her lab values were very low, and we found that she had this condition, DPYD deficiency, that she did not process the chemotherapy out the way most people did. She completed her radiation, had lots of complications due to infection. And then normally when people are done with this radiation chemotherapy process, they have to be on maintenance chemotherapy until they get their transplant. We couldn't use the capecitabine for her because she had such difficulty, and so we started her on gemcitabine and cisplatin. As part of the process of transplant, she had to have an exploratory laparotomy to make sure she didn't have any cancer outside of her original site, and was unfortunately found to have positive lymph nodes, and so that eliminated her from the curative transplant process. So now she is looking at the long-term possibility of being on chemotherapy. So the NCCN guidelines, this is an organization that kind of develops for people who work in oncology what things that we need to use to treat patients with. This is what the guidelines look like, and in that red box you'll see that because of the TOPAZ trial, durvalumab, gemcitabine, and cisplatin is considered to be the first-line therapy for people being treated for biliary tract cancers. You've seen this slide. I'm not going to talk a lot about this because I think it'll probably be talked about a lot. But the thing that is most important for someone like me as a clinician is now, we've been using gemcitabine and cisplatin forever, right? And so we all know how to do this. But now we're introducing this concept of immunotherapy, and so that adds a whole new aspect of side effects that people might be able to or might experience. So durvalumab, it's a fully monoclonal antibody that is targeted against PD-L1. And as mentioned by Dr. Scott, it does make the treatment much more effective when combined with the chemotherapy. It's fairly well tolerated, and probably of the combination of the three drugs, it is the least problematic for side effects. So with cancer immunotherapy, the goal is to stimulate the immune system to kill the cancer. We want to ramp up your immune system so that it can help in conjunction with the chemotherapy to help hopefully shrink the cancer. So if we think about our immune system as an army, these are all of the different cells that are involved in that process. So when you look at the adaptive immune response, there is this adaptive or antigen presenting cell. I kind of look at this as the patrolman. It's going around, it's looking for things that don't belong, and it prompts the T cells to multiply and attack suspicious cells. As the cancer cells break down, the immune system, they become antigens, and the immune system can work in coordination with this MHC complex to try to fight the thing that has been recognized as defective. Tumor cells can be presented to the T cells, and the T cells will target the cancer itself. So checkpoints. I don't know if anyone's ever heard the term checkpoint inhibitor. When you get sick, your immune system activates. If you ever get a cold, you get those lymph nodes that enlarge in your neck, right? That's your system doing what it's supposed to do. So checkpoints are normally present to help the immune system to find things that are abnormal. Cancers, however, can upregulate these molecules and actually turn them off so that they're not recognized as something abnormal. So there are checkpoints including PD-1, PD-L1, and CTLA4. So the program death 1, PD-1, and then the ligand, PD-L1, those are used to as areas of targeting when we look at cancer therapy. But these are the things that kind of mask the cancer from the system so that it's not recognized as something that doesn't belong. So if you block this connection, then you can turn the T cells back on. So a lot of the cancer therapies are referred to as anti-PD-L1 or anti-PD-1. This is just a list of some of the drugs that you will see, and I'm including this because we're not going to talk a lot about durvalumab. We're going to talk more about pembrolizumab. And all of these drugs can have negative effects on the system. It doesn't happen commonly, but when it happens, it's something that you need to recognize so that it can be corrected. So immune-related adverse events, these are things that happen. It's almost like we've turned the immune system on, and the body is attacking itself. So we've turned it on too much, and you start having something happen that we don't want to happen. These can range from mild, you get a little itching, you get a little rash, or they can become severe, and if not treated in a timely manner, can actually be fatal. When we give drugs in combination, say a CTLA and a PD-L1 or a PD-1, then the risk of this is higher. So hepatotoxicity is really the thing that I want to focus on here, because the biliary cancers will often cause problems in the liver just because of where they're located. Immunotherapy can cause what's called transaminitis, where the liver function goes up, or hyperbilirubinemia, so you can get both. So in combination therapy, it can be up to 30%. 15% can develop grade 3 or 4 toxicity. It's usually less than 10% in monotherapy, so when you're only giving one immunotherapy drug, less than 10%. But 0.2% can have liver failure. So if you're giving someone immunotherapy and they start having some abnormal labs, you have to check some things. So you have to make sure that their cancer isn't progressing and making their liver function go up. You also have to rule out infectious causes. So do they have hepatitis? Do they have Epstein-Barr? There's lots of things that you need to check for. So you have to look at, with imaging, you have to ask the patient, are you taking anything that's liver toxic? Are you having a lot of pain and you're taking lots of Tylenol? Is it the holidays and you're drinking a fifth of whiskey every day with your friends? The other thing that I have discovered is that there are a lot of herbal medications that sometimes people don't tell you about that can cause elevation in the liver function, especially when given with chemotherapy. So you have to ask, what's happening? Are you taking something new that we don't know about? And so if you rule out all of those things, that there's not a progression of the cancer, they don't have a stone, then you have to treat the hepatotoxicity, assuming that it's immune mediated. So when you have patients who are on, so for those of you who are not working in the medical field, there's a whole system for how you grade abnormalities. And so there's a chart that you can look at. And so when you look at any toxicity, it's best if you can put a number on it so people who come after you know what happened. So if you just say, well, yeah, their liver function was elevated, well, what does that mean? So you should quantify it in some way. And there's a whole set of guidelines on how you manage immune-mediated hepatitis. So if the thought is that the immunotherapy is causing this, then you treat it based on the grading system. So if it's severe, you have to stop the medication that they're on and give steroids. And so you start steroids at a certain level based on what grade, and then you titrate it down when things start to improve. So back to our patient. Now, because she had Lynch syndrome, she was started on pembrolizumab. At the time we were treating her, durvalumab, TOPAZ-1 had not occurred, but what happened with her is really can be applied to anyone who is on immunotherapy and has biliary tract cancer. So she was started on pembrolizumab every 6 weeks. When she started, her liver function and bilirubin were already elevated. But right after she started, she went and had an ERCP and had her stents exchanged, and her labs started to go down. By April, though, her liver function and her bilirubin had started to go up. And so at the time I thought, oh my gosh, so is this from your stents need to be exchanged, or is it from your immunotherapy? It was really hard for us to know because she had very complicated anatomy. I actually called the gastroenterologist who did her stent exchange and said, you know, what do you think? Do you think this is from her bile duct needing to be, you know, reopened, or do you think it's from the immunotherapy? And he said, I don't know. What do we do? And so what we chose to do was start her on steroids to see if her labs would improve. And they had a little bit of an improvement, but not as much as we would have liked. So she went and had another ERCP. She had some sludge, she had some stones, her stents were exchanged. So by June, she was off of the steroids. Her labs still did not look stellar, but they were better. And so we're in the same quandary, you know, it's better, so, and now she's had her stents removed and cleaned and everything is good. And then we resumed the pembrolizumab. And then about 2 weeks later, she ended up in the hospital with worsening jaundice and cholangitis. She was treated with steroids. She had repeat stent exchange, and she was discharged. We saw her in July with imaging, and her disease was stable, and so we decided that we couldn't really risk continuing the pembrolizumab when we weren't really sure what the cause of her abnormal lab values were. So this is a very messy slide, but I couldn't really make it any better. If you look at the graph near the blue one, you can see how her bilirubin went up and down over time. And so when she started on the treatment, it was elevated, but she had had her stents exchanged, and so everything went down. And then she just was all over the place. And so it was very hard for us to know what was the cause of all of her abnormalities. But if you see on the other graph, that one section where everything is elevated, that's kind of when everything kind of started to go wrong, and everything was very chaotic. Everything was going up and down, and that purple arrow there that's pointing down, that was when we discontinued the pembrolizumab. And so you can see as she continued on, she had a lot of fluctuation, but not quite as much. She had very complicated anatomy. Her biliary tree was very tortuous, as the gastroenterologist said, and she actually had to have ERCPs about every 6 weeks to exchange her stents because they just would get occluded very easily. But once we stopped the immunotherapy, it got less chaotic for her, and so most likely the pembrolizumab was contributing to some of those changes. So it was never clear for us, and it may not be clear to the clinicians or the patients and their caregivers what is really happening here. And so it's important to know that for patients who have cholangiocarcinoma and have a stent, not all patients have stents, but if you do, then it's important that you are attentive to how things change over time. So immune-mediated hepatitis can occur at any time while someone is on immunotherapy. There's really no pattern to it. So you have to be attentive to lab fluctuations and corresponding symptoms. So before we had this quandary with people on immunotherapy, if someone's bilirubin and LFTs started to go up, I pretty much knew that they were probably going to need to have an ERCP to have their stents evaluated, because they were probably developing a problem either on their way to cholangitis or just to a repeat obstruction. But now that we have the immunotherapy, you have to be a little more investigative. So you have to ask the patient, especially if they're new to your center, do you have a stent? And so if you are a patient who has a stent, Do I have a plastic stent? Do I have a metal stent? Because those are managed differently. If it's a plastic stent, it has to be exchanged regularly. If it's a metal stent, it doesn't. But they can both get occluded. And so when you have someone whose labs are starting to change, you have to ask, are you having increasing abdominal pain? Are your stools looking a little different? They probably are. Are you having any fevers? Is their white blood cell count elevated? And so you have to look for other clues that might tell you, are they having an infection or a stent occlusion, or are they having immune-mediated hepatitis? So if the patient doesn't have a fever, then you should probably start steroids to see if their lab values improve. You should grade your toxicities of any kind, but particularly your hepatitis. If someone goes on immunotherapy or steroids, then they should go on some sort of prophylaxis for their stomach. So if you're going to be on high-dose steroids for more than 2 weeks, which you probably are, if you develop immune-mediated hepatitis, you should get some sort of prophylaxis for the stomach, either a PPI or a H2 blocker. And then there should be antibiotics to prevent the PCP pneumonia from developing. At our center, we use Bactrim 3 times a week. And you should taper slowly. A lot of times patients are anxious to get back on their therapy, and so they don't want to be holding it while you do a slow taper. If they're on Gemcitabine or Volumab, you can continue the gemcitabine and cisplatin while you taper their steroids and add the durvalumab back when they get to about 10 or 20 milligrams of prednisone, depending on the situation. If you are trying to do a rapid taper and their labs worsen, you have to stop the taper and go a little bit more slowly, because everyone is going to change, their labs are going to change differently depending on their system. If you have a patient who develops grade 3 or 4 hepatotoxicity while on an immunotherapy, you have to discontinue the medication, and because the risk of them developing a worsening hepatotoxicity is very high. Questions? Boy, that's just like end right there. At the end? Okay. So I think, it's very unclear when you have our complicated patients who have these biliary strictures, what is the real cause? So that probably the most important thing is that you are attentive and that you consider the possibility that they do have some sort of immune-mediated hepatitis.
Thank you so much. That was a very practical and really helpful kind of how to think through things clinically when we're looking at these patients in our clinic. So that's wonderful. Next, I have the privilege of introducing Dr. Junaid Arshad. Dr. Arshad is an assistant professor here and a GI medical oncologist at the University of Arizona Cancer Center. He has been with us for about 2 years now, came to us from completing his fellowship at the University of Miami, and has literally hit the ground running, has already been incredibly prolific and successful in his specific areas and niches, which include upper GI malignancies. And he absolutely is part of our HPB team and takes wonderful care of these patients. And as somebody that I am so proud to mentor, it's been wonderful to see him grow even in just these 2 short years. And so it is a wonderful opportunity to welcome to the stage, and he's going to speak to us about targeted therapies in cholangiocarcinoma.
Thank you very much, Dr. Shroff, for such a kind introduction. My name is Junaid Arshad. I'm a GI medical oncologist at University of Arizona Cancer Center. I'm very grateful to be here with such distinguished group of people, patients, advocates, and it is such a privilege for me to give this talk today. We will be talking about the role of targeted therapies in cholangiocarcinoma. I have no disclosures. The overview of my talk consists of defining targeted agents, the therapeutic options that are available for IDH-positive cholangiocarcinoma, understand the therapeutic potential for FGFR targeting therapies in cholangiocarcinoma, and the role of rare targets. So what are these targeted agents? Everybody talks about targeted agents. Targeted agents are a special class of anti-cancer treatment which works by blocking specific molecules and pathways that are involved in cancer growth and survival. Now, these targeted agents are designed to be precise and specific so that they avoid damaging the normal healthy cells, unlike the traditional chemotherapy. There are different types of targeted agents, and they are selected on the basis of the molecular landscape, meaning the molecular mutations that are present in the tumor that is determined by genetic profiling. These targeted agents can be monoclonal antibodies, they can be enzyme inhibitors, which are involved in the cell cycle regulation, they can be protein formation inhibitors, or they can be angiogenesis inhibitors, which are inhibitors of blood vessel formation that are needed for tumor growth and survival. These targeted agents are the backbone of precision medicine, which is also known as personalized medicine, which is an innovative approach that takes into account individual variations such as patients, genes, environment for the best possible outcome. So I want to, before I proceed, clarify this. The term alteration is a broader term that includes mutations. There are several different types of alterations, which are mutations, fusions, rearrangements, kinase domain. These are all scientific words, but when I use the word alteration, that also refers to as a broader type of mutation. So it seems so easy that, we have these targeted agents, they block certain molecules, and the problem is solved. The actual situation is a lot more complicated than it seems, because this is how the signaling pathways look like. We have no clue what's leading to what. So the part of the problem is that the cholangiocarcinomas are clinically heterogeneous, which in simple terms mean that they are very diverse. They have clinically varying etiologies, they have differing complexities and clinical presentations, and as has been mentioned in the prior presentation, that they vary based on their anatomic location. So intrahepatic cholangiocarcinomas, they arrive from the cells of the bile duct in the liver. Extrahepatic are ampullary carcinomas, or arise at the bifurcation when the right and left fuse, and extrahepatic are the ones that are outside the liver after the right and left ducts form the main bile duct. The role of targeted therapies is primarily in the advanced unresectable cholangiocarcinoma, which primarily means that it is metastatic cholangiocarcinoma where the cancer has spread to outside its place of origin. And as you can see, that the targeted agents are mainly in the second-line setting after the failure of first line of chemotherapy. And there are several different types based on the alterations. This has been a very exciting time in the history of cholangiocarcinoma, exciting for the patients as well as for advocates and the physicians as well. There has been several agents that are FDA approved now in the last few years, which improves the therapeutic outlook for the treatment of cholangiocarcinomas. So the first target we'll be talking about is IDH1, which is a fancier name for this is isocitrate dehydrogenase mutation. Don't have to remember that, just IDH1 will be sufficient. 15 to 20% of these are present in intrahepatic, less commonly in extrahepatic outside the liver, and very rarely in gallbladder. Now, similar mutations, the same IDH actually mutations are present in gliomas as well, and they are considered prognostic, which means that patients with the mutations have a different survival as compared to the patients who don't. The prognostic role has not been established in cholangiocarcinomas. The first trial I will be talking about is CLARE IDH1 trial, which led to the approval of this first targeted agent, which is called ivosidenib, in patients based on a global phase 3 randomized trials, which means patients who were previously treated with chemotherapy who are in the advanced unresectable setting were divided into two groups to receive either ivosidenib or placebo. And these tumors were the ones which had IDH1 mutations. The patients were allowed to cross over, which means the patients who were in the placebo arm were allowed to enter into the treatment arm upon disease progression. So the primary endpoint for the trial was progression-free survival, which basically means that the time duration from starting the treatment to the disease progression, which is different from the overall survival, which Dr. Scott mentioned was the endpoint in some of the earlier trials. So the results from this trial showed a favorable clinical survival benefit in favor of ivosidenib, and that together coupled with the favorable safety profile, which means having favorable side effects, favorable but manageable side effects, a supportive quality of life, and statistically significant progression-free survival led to the FDA approval of this medication, ivosidenib, in patients with advanced unresectable, previously treated IDH1 mutant cholangiocarcinomas. Then there are several other novel agents that are currently under study, which are looking at the role of these agents in previously treated IDH1 and IDH2 mutant cholangiocarcinomas. And I haven't mentioned IDH2 before, but IDH2 is also similar to IDH1. It is located in mitochondria, which is the powerhouse of the cell. This is a two-part study. Part one is to just test the safety and tolerability of these novel agents in patients who are previously treated cholangiocarcinoma with IDH1 and IDH2 mutations. And then there is a phase 2 dose expansion part that shows at the bottom, which after determining the safety and tolerability will determine the dose, and that will be tested in combination with chemotherapy, cisplatin, and gemcitabine in patients who have not received prior chemotherapy. So this combination will be tested with chemotherapy in the frontline setting. The results from this study showed that the side effect profile was favorable. I would like to spend some time trying to explain this graph, which uses the term of overall response rate or objective response rate, which is in simpler term means the tumor response rate, where each bar represents a single patient, and the extent of each bar, how long it proceeds, shows the treatment duration in this. But in simpler terms, this is a waterfall plot that shows us the response of the tumor. On this slide, this is the same waterfall plot that on y-axis in the negative means shows that reduction in tumor size, and each bar represents a single patient. And based on this study, the dose expansion, the second part of this study, this novel combination and chemotherapy showed a tumor response rate of 46%. And the progression-free survival at 6 months was as high as 83%, which is pretty high as compared to some of the earlier trials that were mentioned. This IDH mutation also affects the immune system. It leads to decreased migration of immune cells towards the tumor, which basically suppresses the immune system. That means it leads to the immune escape of the cancer cells, which led to this novel idea that we can combine this ivosidenib medication with immunotherapeutics that have been discussed before. Also, this is a two-part study. Phase 1 part of the study looks at the safety and tolerability and determine the side effects of this novel combination and determine the dose. And the phase 2, which is the dose expansion part, the second part of the study, has 2 cohorts where the patients with IDH mutation who have previously received chemotherapy, the patients who have received prior immunotherapy will be included, and then there's a second cohort for the patients who have not received immunotherapy will also be included. The results of this trial are underway. It's currently ongoing. The second target we will talk about is the fibroblast growth factor receptor, also referred to as FGFR. It's seen in primarily in intrahepatic, cholangiocarcinomas, less commonly in gallbladder, and rarely in extrahepatic. This target has been subjected to therapeutic intervention in several clinical trials, and having this specific type of alteration is prognostic, which really means that if the patients having these types of FGFR2 fusions have a better survival as compared to the patient's tumors who don't. That brings us to our first agent, pemigatinib, that was FDA approved based on a single-arm, open-label, multi-center study in patients with previously treated advanced metastatic cholangiocarcinoma after failure of chemotherapy, who had FGFR2 fusion type of alteration, and the tumor response rate based on this was 35.5%, which led to the FDA approval of pemigatinib for patients with FGFR2 fusion alteration in metastatic cholangiocarcinoma after failure of chemotherapy. Similarly, futibatinib is another such targeted agent that was approved by FDA based on a similar phase 2 multicenter study that showed that patients with advanced unresectable after failure of chemotherapy who have FGFR2 fusion type of alteration showed a response rate of 42%, and which led to the FDA approval of futibatinib in September 2022 in patients having this alteration in the metastatic setting. Then erdafitinib is one of the newer agents that has been currently being studied in Ragnar trial. The results, the dose expansion or phase 2 part of the study were presented earlier this year in the GI ASCO Symposium, and the tumor response rate in this case was as high as 60%. Then there are several other ongoing trials that are preliminary results that are available. FIGHT 207 study is another such trial that is another multi-center study that studies this pemigatinib, the drug that has already approved, but only in certain fusion type of mutations. Now it is being studied in all different types of cancers that have FGFR fusion mutations as well as other non-fusion type of mutations. So there are 3 cohorts. Cohort A includes all tumors with fusions and rearrangements. Cohort B includes the alterations which are not fusions, which are called in fancy terms as single nucleotide variations. And cohort C includes all other type of mutations which have not been studied before or which we initially thought were not beneficial. So this graph, although it seems there's a lot going on in this slide, but the key point over here that the responses were observed in all cohorts, regardless of the type of mutation, including the patients with FGFR alterations, which we previously thought were not actionable or not beneficial, and previously uncharacterized, meaning that they were not studied before. This study also looked at the use of ctDNA to look for baseline mutations and resistant mutations, and which just gives us information that for patients for whom these targeted agents don't work, they are found to have some of the resistant mutations, some of which are shown on the slide, and basically this resistance is conferred by clash with the FGFR receptor binding site. Similarly, lirafrugratinib is one of the newer agents, which is an irreversible inhibitor of the FGFR2 receptor, and it is more potent as per the initial reports, meaning that it is thought to have a lot more activity against these type of alterations. This is based on Refocus trial, which is also a global Part 2 trial. It has 6 cohorts. The top 3 cohorts are in cholangiocarcinoma as shown. It includes the FGFR receptor 2 fusion mutations. It is different as it allows the patients who have been previously treated with these FGFR inhibitors. So it allows the patients with previous treatment with these previous inhibitors, other agents, and FGFR2 which have not been treated with any agent before, and a different type of FGFR2 mutation. And you can see this from these waterfall plots, all these lines that are below the baseline that shows the response. The response rates were as high as 58%. Similarly, the patients who have received targeted agents before, there were response rates were observed in those as well, as high as 21%, even though lower than the patients who have not received prior targeted agents. Similarly, FGFR2 mutations other than fusions were found to have a tumor response rate of 64%. Cholangiocarcinoma is another newer medication, so we say it's a newer kid on the block. It targets the FGFR2 receptor binding site away from the original binding site, which makes it distinct that it can bind to the receptor in its active form, which makes it really exciting to study for resistant mutations which can be present after treatment of prior targeted agents. The results of this study are very satisfactory, and they're currently underway. So let's switch gears to rare targets. So HER2, it's a human epidermal growth factor receptor. It's the same HER2 that's present in the breast cancer and the stomach cancer. It is present more commonly in gallbladder cancers, less commonly in extrahepatic bile duct, which is outside the liver, and less commonly in intrahepatic bile duct. And there is a newer agent, zanidatamab, and this was initially University of Arizona Cancer Center was part of one of the trials that showed that zanidatamab binds more actively to this HER2 target as compared to trastuzumab and pertuzumab, which are prior drugs approved from breast cancer. And preclinical studies have shown the activity of zanidatamab, and phase 1 studies have also showed that this has favorable safety profile, and which led to this study, Horizon BTC-01, which is a phase 2 study. They were studying in patients who have HER2 amplified tumors who have failed prior line of chemotherapy. And the results from this trial showed a tumor response rate of 68%. Similarly, there is another trial that is looking at the combination of trastuzumab and tucatinib, also one of the 2 breast cancer medications currently being studied in all-comer tumors and cohort 3 is specially targeted for biliary tract cancers. And the tumor response rate from this trial was 70%. Also, the progression-free survival and the overall survival at 6 months were very satisfactory. BRAF is another rare target which is less commonly present in cholangiocarcinomas, and FDA approved this agent, dabrafenib trimatinib, back in June 2022 in patients with metastatic cholangiocarcinoma if they have mutations. MDM2 is one of the newer targets that has been currently under study, and there is a new trial that's currently studying this new targeted agent in all types of tumor types having this alteration. Other rare targets that are currently available are NTRK type of fusion mutations, for which larotrectinib is the medication that's approved, and RET gene fusions are also FDA approved, selpercatinib. These were the agents that were approved on the basis of all-comer tumors who have these rare type of alterations. So this is my last slide. My apologies if there are any French understanding people over here. My partner told me to say this right, so I practiced this last slide a lot more than I practiced my whole talk. So let's give it a shot, and my apologies. L'avenir est prometteur, which means the future is bright despite a shaky start. We know that IDH targeting works, and we have trials that prove of that. How do we build on that? That brings us to the role of immune microenvironment in combination studies. We know that FGFR targeting also works. We have 2 FDA-approved medications, and we're building on that to develop more potent and more efficacious drugs. So the future is bright. There are several different types of studies that are coming, and it improves our understanding of resistance across the targeted therapy space. Before I head on to the questions, I will end my talk with a beautiful quote I found. Even in the face of adversity, the human spirit finds resilience, just like a river that finds its course despite obstacles. May the journey for cholangiocarcinoma be met with courage, strength, and unwavering belief in the power of hope. Thank you very much. And a huge thank you to everybody, my mentors, patients, caregivers, and Cholangiocarcinoma Foundation. This was the first talk to make me a member of the Cholangiocarcinoma Foundation family. Thank you.
All right. That was a very comprehensive look at all of the various clinical and therapeutic things that are happening currently in the space of cholangiocarcinoma. And so thank you all for your attention. But now we would love to have some minutes, some time before our break for questions. Dr. Arshad, please join us up here. Kelly, please join us up here. We've got people walking around with microphones, so if you can, please just wait for that microphone to get to you. But I will open the floor to questions. I mean, I can come up with questions. There we go.
So earlier in the immunotherapy treatment talk, I recall there's a comment on better response with gallbladder type to the immunotherapy. I wonder any thoughts on the mechanism behind that?
To clarify, I think maybe I minced words. That might have been around the GAP study, the triplet regimen, gemcitabine, Abraxane, and cisplatin. So there's actually not an immunotherapy in that regimen. That was just chemo. And the question is really important because there was such a stark difference between the triplet versus the doublet chemotherapy, which is just gemcitabine plus cisplatin alone. We don't know, to be honest. We're not sure exactly why that triplet regimen works so well in gallbladder and not the other subtypes. There might be an immune component there that's just undiscovered. And as I mentioned, there is another trial that's soon to be activated, if not already enrolling patients, using that regimen, the GAP regimen, in locally advanced gallbladder cancers. So I think it's important in context to understand we're still very much in the learning growth curve, especially for very rare. Cholangiocarcinoma is rare. However, gallbladder cancer is a rare subtype of cholangiocarcinoma. So we're dealing with small numbers. And I think there has to be a lot more investigation into why that triplet regimen worked well. So I think it's going to be a cooperative group study. So it'll be open nationwide across the board and NCTN sites that open NCTN trials. And we're very eager to see what the outcome is. And I think as important to understand the biology, getting the biospecimens, the biopsies, et cetera, to understand their characteristics.
Other questions? Oh, there's, oh. Here we go.
Hi, this might be sort of a very basic question. You know, I'm a caregiver, so obviously not really into the technical weeds. But so from what I understand with all this, even with the targeted therapies or even with additional therapies, based on those earlier studies, you still start with the cisplat, you know, the regular standard therapy. The only question I have is when you start doing a lot of these targeted therapies and clinical trials and things like that, how does it work when the you know, cancer may not actually be identified where it came from? You know, can you still participate in some of those? And how does it work when the cancer is maybe, you know, presumed cholangiocarcinoma, but maybe not confirmed just based on what happened? Just swallow.
Thank you very much for the question. These are relatively rare tumor types. So to answer the first part of your question, that targeted agents, we start testing them with phase 1 in the patients who have failed prior treatment regimens, and then we determine the safety from those trials and see if there is any signal in there. And if once we find the signal, then the same medication is also tested in a larger group of study, which is called like a phase 2 study in the frontline setting too, to see if this will have this is all part of the clinical trial design ways, and it has a lot to do with ethics too. A newly tested agent, we cannot give it to the patients when we clearly have options which we know that they work. The second, I think the half of your question was related to when we don't know if there are. So there have been several studies that, and this molecular typing is part of the this consortium that we're trying to molecularly type these tumors. And a lot of times when we don't have the disease that's present on the scans, we're working on to develop assays which we can find the DNA of these tumors in the blood. So, and then have some sort of molecular mutations related to the tumor, and then we can match it to our database. So to answer your question, currently there is nothing really that is approved for now, but there is a lot of work that is going on in this setting, building up databases and looking at these blood-related tumor markers.
And I would just add, so, you know, we typically call those carcinomas of unknown primary, right? And actually one of the slides that I think Dr. Scott showed, when we look at some of the epidemiology of increasing incidence, for instance, of intrahepatic cholangiocarcinomas. There's also that data that Dr. Javle published demonstrates also a decline in the carcinoma of unknown primaries, which I think is, a little bit hopeful in that we are getting better with pathologic diagnosis and kind of putting together the entire puzzle when we look at the radiology, the pathology, because, pathology comes back as adenocarcinoma, pancreatic or biliary or upper GI. I mean, it's not necessarily specific because they all look very similar on slides, but I think we're doing a much better job of just putting together the entire clinical picture and hopefully being able to kind of decrease the number of carcinoma of unknown primaries and really kind of reclassify them as cholangiocarcinomas, because a number of the cups, as we call them, are cholangiocarcinomas. But, like Dr. Arshad mentioned, there's also a number of kind of diagnostic techniques and technologies that are being developed to also hopefully help us with that space. But for now, clinical trials do technically require what we call a confirmatory diagnosis. I will tell you, and I've said this story to people, so you may have heard this before, but as the national PI of SWOG 1815, a lot of the questions on pathologic diagnosis came to me as the study chair, and so I would get the pathology report and the radiology report, and to your point, community oncologists or whatever who are seeing a lot of different diseases and maybe aren't seeing as many cholangiocarcinomas as some of the larger centers, you kind of put it all together, and they were about to be excluded from the trial because they were being called carcinoma of unknown primary. And as the study chair, I kind of overrode that because you were able to really look at the whole picture and say, this is actually a cholangiocarcinoma. So, that is probably something to think about in patients who have quote unquote carcinoma of unknown primary with clinical trials is, pinging the national PI or whoever's kind of running the trial to see if they are willing to recognize the diagnosis.
You run, I'll switch.
I'm very new to cholangiocarcinoma. I wonder, when does surgery come into play? Is that ever like a treatment option? And how do you integrate all these different possibilities?
I mean, I can let our medical oncologists and advanced nurse practitioner answer, or I can put Dr. Ryle on the spot if she wants to. Our surgery talk is coming, but is it okay? Okay, I'll just run it up to you. Dr. Ryle is our chief of surgical oncology, so I figure she's the right person to answer that question.
There is most certainly a role for resection in cholangiocarcinoma. Unfortunately, only 20 to 30% of patients who present with cholangiocarcinoma are at an earlier enough stage that we can do that. I'm going to speak this afternoon about different surgical options. I'm also going to combine some of the other local regional therapies and taking patients who don't have disease that's amenable to surgery and then making it amenable to surgery. I'm also going to talk about liver transplant, but there's most certainly a role.
And I would also just say that now as our therapies are getting better, just to Dr. Ryle's point, we're really trying to think through, okay, maybe you're not resectable up front, but what could we possibly do to get you to the operating room? And so, you'll hear from our interventional radiologists in terms of some of the techniques that they have. And as our systemic therapies are getting better, we're starting to think about what we call neoadjuvant or preoperative treatments in an attempt to try to get somebody, because we know that surgery is that curative approach, and so anything and everything that can be done is being considered in a very multidisciplinary manner with a engaged multidisciplinary tumor board. That's important.
I have a question. So just some of the conversations I was having today, can you guys touch on the biomarker testing, when it has to be tissue versus liquid, and how often should it be repeated and when?
So I think we prefer tissue testing, but we can't always get tissue depending on the situation. And so we prefer tissue testing, or at least we do at my center. I assume you guys do too. The trouble with tissue testing is sometimes one, we can't get tissue. Two, it takes a while. It takes up to a month to get the results back. And so we will often do the liquid tumor testing because we can get that much more quickly. I know there are two different ways to use the liquid tumor testing is at diagnosis. Some, like where I work, we use the liquid testing in between if someone progresses to see if there are any new or changes in the mutations or we want to see if their molecular profile has changed. If it's changed, say they have something that's new that we can target, then we use that testing for that. I know some centers will use the circulating tumor DNA to see if their tumors, the profile is changing as they get treated, to see if that is giving them an indication that the treatment response is more robust. But we use it more when people progress.
Okay, so we touched upon a concept of how therapies can change the immune cells. So I want to expand a little bit on that, about the tumor microenvironment. I believe for cholangiocarcinoma, there's a lot of fibroblasts in the stroma as well. So any thoughts on that? How do those stroma cells respond to therapeutics? Is there something we can learn from the stromal cell perspective to help with treatment?
I'll take a stab at that. Fantastic question. I think you're really speaking to where a lot of the field lies in terms of the brain power and efforts behind understanding the tumor microenvironment, because we know it's not just cancer and then everything else, normal tissue. In general, most GI cancers, and this is not just cholangiocarcinoma, but certainly includes cholangiocarcinoma, they can develop this milieu of cells. So you have a composite of different immune types, support cells like fibroblasts, and then the cancer cells. And when you look at cancer under a microscope, it's not just one big tumor with many different cancer cells, it's all of these other cells intermixed. So you'll have pockets of cancer surrounded by fibroblasts, and then you'll have this infiltration of immune cells. All that to say, there are targets being developed to all of these different components. And chemotherapy tends to kill everything that's dividing, right? So there's an impact on all of those different cell types and compartments within a tumor. And you zoom in, it's going to have an influence differently on different tumor types or cells. But we do think that there's an impact on, like I mentioned, there's pro-immune cells and pro-fibroblasts that are pro-tumor, and anti-tumor lymphocytes and T cells and fibroblasts. And what we see is that chemotherapy generally, at least initially, seems to impact the pro cells to a higher degree. That changes over time. And so it's a very complex question, right? Is how does this look over the course of 6 months of chemo? And there's certainly a continuum there. The dynamics are important. But to answer your question as specifically as I can, there are actually targets at those fibroblasts now. So there's a couple investigational agents that we actually have open here at our University of Arizona Cancer Center that are specifically targeting fibroblast activating protein, which is expressed on these fibroblasts. It's a bispecific antibody. And that will link immune cells that are important for killing cancer with those fibroblasts that surround those cancer cells and bring them together. And so this is a big area of investigation and a very important question.
Are liver transplants becoming more of a viable treatment option if the cancer has not spread past the liver?
Dr. Ryle.
Oh, okay.
I want to just jump this step really bad. Yeah.
This is really not related to necessarily your talks in particular, but I wanted to mention it now because you spoke about letting people know about the foundation, and I feel like I'm picking on Dr. Arshad and maybe Dr. Schroff a little bit because they both work at the cancer center that my mother is being treated at. So when we first, I never heard about the foundation from any of like the treatment providers or from the cancer center. And I found out about this through a Google search, right? And that's how I found out about the foundation. And they've been a really great help, both in terms of like that kit, you know, that you guys sent us that had things that we got recommended by some of the palliative care people at the cancer center, right? Like that, the lotion, right? It's really simple things like that. And also the information that you gave us. And just in general, you know, talking, like I have a mentor through the foundation and, you know, especially, you know, given some of the, you know, where you get diagnosed, the staging, things like that, when you get this, you get kind of hopeless, right? And they've given us hope. And also when it came to even doing chemo, right? And, you know, I didn't feel good about chemo, right? Until I talked to the mentor, right? Until I talked to someone who's gone through this, right? So I think that it helped at least me, you know, it helped you clinically treat, you know, well, I'm not going to say, because I'm not going to speak for my mother, but it helped me feel better about the treatments that you were giving, hearing about the foundation. So long intro to that, but how can we get the clinicians and the first-line providers to connect us with the foundation? Like, how can we make sure that that happens? Because you guys are here, obviously, you know about it, but like, even when we were getting treatment, we didn't even hear about this, you know? So how can we make that a better connection?
We had no way of knowing that there was anything that can be done because I was told that if I didn't adhere to chemotherapy, if I didn't want to do chemo, there was nothing they could do for me. That was it. It was the end of the line. That shouldn't be the case.
Yeah, no, I think that's a really wonderful point, and you know, I think that's why the foundation is such a wonderful partner with a lot of us. And you know, to Stacy's credit, Stacy landed yesterday midday and came to our clinic to figure out how, you know, in the middle of a very busy practice, how the foundation can provide resources and support our physicians, our nurses, our APPs, and everybody that's seeing the patients. And so, you know, we talked about some of the materials because they have incredible materials. We talked about getting some of those materials to our nurses so that after we see our patients, that our nurses can make sure that the patients get those resources, get the, you know, the link to the website, which is just, you know, the start of a vast amount of information for our patients. And, you know, I think that is going to be the way to do it. I think it'll be to think through how the foundation is able to provide the resources to our teams so that our teams are able to do that. And you know, I think that's exactly their mission, I know for a fact, because I've seen it, and is absolutely, you know, something that the University of Arizona Cancer Center is committed to as well.
I mean, just the terminology itself. I had no idea what some of these terms meant or what this disease was. And this booklet that was sent out in this kit was a godsend for me because now I knew what in the hell I was dealing with. Before that, I had no clue. So.
Well, you guys are my new poster child. I'm putting your everything on the front page.
Yeah, just a couple of things I just wanted to also add. It's just a lot of times I know the burden falls on the clinicians too, but we work together as a team. And if the palliative team mentions and everything, so this is all part of the team. Absolutely.
One more right here.
Yeah, I've got one here. Okay, this is wonderful. This is spot on. Your target, your audience, the information coming to you is great. Now expand your circle. It takes an hour and a half one way to drive here. Okay? You've got a lot of patients that are outside this local area. Okay? Now I got the tough one already answered. Okay? I want the first speaker's PowerPoint slides. Okay? And she's going to email them to me. All right? There's a bunch of other providers here that can use that information. It needs to get out. Okay? Thank you.
Thank you.
Yeah, there's a lot of discussion about mutations and targeted therapies for the mutations. Do most cholangiocarcinoma patients have some type of mutation? And are those the ones that, if they don't, do they have targeted therapies for those people?
We're learning. The mutations that have been described in large part represent a minority of patients, right? So there's been a couple similar slides presented already about all of the different mutations that we see. And we say mutations, it really is a wide variety of molecular characteristics, right? It's not just the genes, but it's proteins as well. And there's a long list of molecular characteristics that we can and are targeting in trials and research. So again, I think the good news is we've made great headway in a minority of patients, and we are trying to expand that. There's a lot of different signals and targets that we have. So we're just on the forefront of this new era. We throw around the buzzword, precision oncology, but it really is biliary tract cancers that I think are kind of the poster child for GI tumors in general. I mean, this is applied to all cancers, not just biliary tract cancers. And, we chip away at what we can over time.
So my comment about this is, so I became a nurse practitioner in 2014, and I actually went to a genetics conference, and they were talking about all these very new and exciting things. And since then, the number of new mutations and, how much has changed in that short amount of time is mind-boggling. And so I think if we don't know about a mutation now, we may know, 100 more in a year because it's so rapidly evolving. Now, we won't necessarily have targets for all of those things, but we have more information to look at and work with.
So a majority of these patients then are not really going to have the opportunity to have this targeted therapies then.
I just want to add that that's what I think makes the immunotherapy trials so compelling, right? Is I try to hit the point, and it, it's hard to do in 20 minutes, but those trials, first-line trials, are applied to everyone, right? There was benefit seen across almost all subgroups. So yes, we're looking for specific mutations, but man, the magic bullet is what can cure everyone, right? Or treat everyone. And that's, I think, the real beauty of combining the immunotherapy with the chemo. So there's a little bit of lumping and splitting still, right? And it's that interplay that I think is really important. I just want to comment on molecular profiling, which is I'm in the club where we should be profiling everyone at all times, all stages. Not the most cost effective, but when it comes down to understanding this disease type in a rare subgroup of tumors, we need that information. So I'm a fan of doing blood and tumor tissue testing at the outset of a diagnosis, and you carry that forward across the spectrum of response, like that's been said.
Thank you.
One last question, because I want to make sure we have a little time for the break. So
I'll make it fast. It's not a question so much. My name is Jennifer Wild, and I'm a nurse over at UCSF. I don't know if there are any other nurses or patient navigators here, but if there are, please feel free to come find me during the break. I want to speak to what the patient family in 2 rows in front of me shared about how hard it is to connect with these kinds of organizations, to find us. And I just want to say that at UCSF and GI Medical Oncology, whenever we have a patient who calls for their initial referral request, or if we're calling them because we got a referral from their doctor in the community, we are always trying to tell the patients about CCF, about PanCan for pancreas, about, there are organizations like this that our experts are involved in, and we're very lucky as nurses there to know of these organizations. So if you're a nurse navigator or a patient navigator, I would really encourage you to just tell your patients about this stuff when they're registering. Before I became a nurse 20 years ago, I was a patient registrar, and so people would ask me these questions too, and I'm like, I'm not a nurse yet, so I don't know if you've heard of this thing called Google. I mean, back then nobody had, but so I'm just saying it's really easy to just bring it up. If you're a nurse, just bring it up to them, spell it, because they probably can't spell cholangiocarcinoma yet. But yeah, happy to talk with any other nurses here. Thank you for your time.
Thank you.
All right, thank you so much. This was great. Clearly, there's a lot of questions, which is wonderful, and that's how we like it. So, all of us will be around during the break, but I just want to give everybody, let's do 10 minutes instead of 15, if that's okay, and we'll regroup at 11:50 with the next set of talks.
I saw you working on your slide deck. It's half the reason I came over here. I'm the Josh that you emailed everything to, and so let's see what wanted to make sure and fix Bill's name there. Let's here plug yours in there. I saw your editing. I'm like that looks exactly like her slide deck. And I'm like. It's so on the spot. I love it. All right, so here's yours. So I have yours here. So let's see if we can open up that slide deck that you just put in there. I have to find set drive. It made the cute little boop noise. I don't see the drive. This is so much more efficient, and I appreciate everything you've done here. Oh, wait. This one? Oh, I love it. Okay. I know. What I always do is, I'm a graphic artist, so I always review, and then it's like final, because I've had so many things go like final. So let's select all of these. Let's do it by hand. There we go. Copy. So let's just make sure only yours has been selected here. Correct. That's what you're seeing. Let's see if we can just delete them. Excellent. And then we're going to duplicate this because I figured this out. Yep. Duplicate slide. And we're going to make your section here. There we go. Just so it matches form here. And then let's put you in here. MD, correct? Mm-hmm. Excellent. And then now we're going to hope that the paste is in the right spot. Oh, I want to make sure everything is in. Okay. Excellent. Yours is going to work really well because what's coming up is the case study that Dr. Ryle is presenting. And so I saw your screen. I'm like, that's going to just work really well together. All right, so we should be good to go. Right, are we running really late? We are about 15 minutes late, but again, we cut the break short just to make up for it. Mm-hmm. You're so welcome. Oh, let me eject it. Oh, I gotta close this. This one is just yours. Didn't save, so we didn't make any changes. Anything to be open? Yeah. 'Cause I know that one goes to the. Okay. There we go. So let's see if we can just delete them. Okay. Excellent. And then we're going to hope that saved. I think it's here. I think that ought to be it, if I'm not mistaken. 11:45 a.m. That's exactly where that is. Let's close PowerPoint. Great. Now let's see if we can eject you. Oh, I see. We have to close this. It was probably fine the whole time. I'm a Macintosh user, so I'm in uncharted territory. Let's close all windows. I love that it keeps. You are free to break. Yours.
All right. I know that that was a very brief break, and everybody really is enjoying gathering. But if you don't mind, if we could take a seat and keep moving, I would really appreciate it. All right. So next we have what is always one of my favorite parts of these type of symposia, which is the patient story. And I have the privilege of introducing somebody who I know quite well, Bill Shaw. So Bill is, you know, a local celebrity and a high-powered man, but he's also just a wonderful human. So he actually worked at KVOA Communications, which is one of our local channels, as president and general manager and senior vice president of Cordillera Communications back in 2009. And he's literally had this incredible career and arc in television broadcasting for over 40 years. And so we're so delighted to have him here speaking today. He does so much additional just work and philanthropic support of our community, especially related to public health. And so, like I said, I got to meet Bill a little over a year ago now. And he is here to tell us his story and his journey. Please welcome him.
Thank you, Doctor. Good morning. So if I try to figure out what I would impart to this group, most of you are a lot more intelligent than I am. So I'm not going to go over all that medical stuff that was up there, but rather what I experienced and what I think. And one of the things I don't want to forget is about finding out about this foundation, because I was in the communication business. We have to communicate that. That's very important. And you're right, I didn't know about it until I met Dr. Schroff. So here's where it all began for me with the cancer journey, as I call it. My mom had cancer when I was in 6th grade. She lived until she was 27. Then my brother died at 48, my sister at 50. And I said, what do we do, live near Love Canal or a nuclear plant? Why is this hitting my family like this? So my mother's side, of 17 kids from 3 women, 9 of them didn't make it to 55. So I was going in every year for a colonoscopy. I think I lost count at 20 colonoscopies. So I was a pro at it. And not something good to be a pro at, but you know, if you have to, you should go in to be checked up is the lesson I learned. Then they found a melanoma on the back of my left leg when I was 29. And the first 3 doctors I went to said, you've probably got 2 or 3 years to be around and we need to take off your left leg. And I said, well, that's not good. I was a big jogger and skier and played golf and swam and cycled. So I went around to different doctors, and I found a doctor at Yale New Haven, Dr. Jean Bologna. Brilliant. Off the charts brilliant. And she said, no, we don't have to take your leg. I've got a great surgeon. We can get you through this. She did. Wonderful. So I learned a valuable lesson. I'm not going to understand everything up there, nor are any of us lay people. But if you find the right doctor, that's the search. So when I was leaving Connecticut, my doctor there told me, you have to be genetically tested because there's something in your family. You can't have these numbers of people pass away this quickly. So I came here and had genetic testing in the facility, which wasn't Banner then. And they were wonderful people, and the doctors checked out great. And they told me you need to have your colon removed. And this was 15 years ago. So I talked to my regular doctor. He says, probably a good idea, you know, because nobody's making it past 55 that are your cousins. So the day that I went in for the final thing before the surgery, I went to work out as I did virtually every morning. But I thought I was forgetting something, and I couldn't remember what it was. And it was really bugging me, and I worked out and showered up. And as I showered up and to get dressed, I realized I forgot my underwear. Big bad move going to see a doctor. So I went to see this lady, and she asked me all these questions as doctors do, and I answered them to the best of my knowledge. And then she said, well, you know, I need to examine you. And I said, well, doctor, did you ever hear when you were little that you always had to wear clean underwear before you went out? Because if you got hit by a car, the doctors would see that you had dirty underwear on. So she says, well, I have heard that, but it's pretty odd. Why are you bringing that up? I said, well, you said you have to examine me, and I got to tell you, I don't have any underwear on. And she said, actually, all I wanted was your temperature and blood pressure. So the reason I bring that up is don't worry about asking these doctors or nurses anything. And that's a clue. Also, pick the right doctor. So I had friends all over the country because of my business background. And everybody's advised me, get to Sloan Kettering, get to Mayo Clinic, get to Houston, get here, get there. And a good buddy of mine who's a patient of Dr. Schroff's said, you can do that, but you got one of the best doctors in the country a mile from your house. What are you going out of town for? And that's been true. So what I learned at Yale has helped me through the years. You pick the best doctor, I think she is, and her resume was unbelievable. And then the supporting staff, the nurses and the doctors. I was in and out of the hospital mainly to the emergency room 7 times, and which isn't pleasant, but I never ran into anybody in this profession that wasn't very caring and meant well. Maybe stretched a little thin because of the staffing issues around the country, but really a dedicated group of people. So what happened with me is my wife, Camille, said, you're turning orange. You can't tough this out anymore. Go to the hospital. And they found the tumor. And I remember the doctors, a young lady, said, she broke the news to me so beautifully. I said, you ought to record this for your compassion because you deal with tough stuff all the time. And we as patients don't see a lot of that. The analogy would be, everybody wants to buy a restaurant. Would you ever run a restaurant? No, but it looks fun. It's not. It's a hard work. Same thing with what is done here. So from my perspective as a patient, I went to Dr. Schroff. Luckily, I get in to see her. And the other thing that I would tell you that maybe doctors and nurses maybe don't think of is you have to have somebody there with you. Because when you get a news like cancer for the second time, I'm not thinking straight. I don't know if you all could, but you're receiving news that's pretty tough. And without Camille, I wouldn't have known what was going on. So I have a friend of mine here, John Duvall, used to be a patient of Dr. Schroff's also. He said, look, if you get the right doctor, everything is going to be fine here. And it has turned out beautifully, and the hospital is great. And yes, there's a systemic issue of lack of nurses and all that, but it's not without good intent on all these health providers' part. And the amount of work that they put in and the dedication is unbelievable. So from a patient standpoint, my brother was talking to me. He said, well, how are you not depressed over this? How are you not upset? I said, because, first of all, I really believe in the being up above, whether it's a man or woman, I don't know, hope they're nice. But when this doesn't work out, which is going to happen to all of us, I'm going to go upstairs. So I don't let that part get to me. And people are kind of surprised at that. And Camille's, went through all this with me. And there were a lot of tears, but not for me, really. I just said, well, I'll trust in the doctor and whatever. So I had lunch with John, and he says, so what are they giving you as far as chemicals? You're going in for, how many, 16 chemo treatments? And I said, I'm not really sure. He goes, how do you not know? I said, because I have Dr. Schroff and Camille, and they're watching everything. So I trust in this system more than anything else. So what happened to me is I kept getting these horrible stomach pains I couldn't figure out. My doctor couldn't figure out. Endoscopy, colonoscopy. I never heard about cholangiocarcinoma like most of us didn't, and I agree with you. The communication process about this foundation, because I was in the communication business, is critically important. I thought I did all my research. I didn't know about this. So where they have that pain chart that says like 1 to 10? Put the sign right below that or above it says foundation. And we know who to call or what the website is to find it out. I also believe that there should be some public information like a PSA that would go on a television station so that people at large know this, because even if you're not affected by it, good chance somebody in your family is, or somebody that you know is, that doesn't know about this support system. And back to the hospital, met some wonderful people with Dr. Nogami, who told me I was full of crap about my fishing stories. But he's a really funny guy. And we still talk. He texts me like every week. And I met wonderful nurses. Dr. Schroff's, the cancer center is great. So you have to take time to appreciate what they're doing. At the same time, they're very busy. So Camille, who's sweet as can be, takes copious notes, and then if there were errors, and there were some errors, she's there to say, nope, here's what you said on February 2nd, here's what happened on the 5th, here's what happened at this, and by the way, you're supposed to follow up on this and whatever, and she goes from the sweetest woman in the world to like that detective Columbo. She won't let it go, and then as she's walking out, she thinks of another thing to ask, which is great, because I don't. So I put my faith in other people and upstairs, and it's worked out well, but it's a tough, tough deal. I can't minimize that. When they say cancer and terminal, it ain't fun. So that's what I rely on. That's my experience. And back to the foundation, I think this is wonderful. So I'm going to get involved to as much as I can. And friends of mine in town, help me get into the hospital and all that stuff. But I think communicating this on a broader sense is wise, and I'll look into getting on TV for the foundation and the hospital. And I'll look to publicize this disease because it was a mystery to me, and I found out the hard way. And Camille, being nice, kept on telling me, have some chicken soup or something. I said, yeah, but I can't eat it. As soon as I eat it, I throw it up, so it doesn't do any good. And then we just got to the point, and they found it. And then the doctor at Banner, Dr. Abood, who had to tell me the news it was cancerous, which in my case wasn't a huge surprise, but did it very factually, but with compassion. And I think my sense as a patient is I love the intelligence and all the hard work and the discipline that goes into all that, and then be able to retain compassion in that process, to me is really great. So I take away all the good stuff, and if somebody made a mistake, not the end of the world. So when I was in the hospital, Dr. Nagami would come to see me before I knew Dr. Schroff, and then this male nurse was there, and I had a bunch of people in my room visiting me, my brother and stuff, and he made everybody sing It's a Wonderful World. Like, where does that come from? And he goes, my shift is over, I just thought they should sing. I go, yeah, get them up. So my brother says, I don't really sing. I said, you're singing, get up. So I take the positives that happened with all this and try to forget any of the mistakes that went along with it. Besides, Camille will be on your case for that. So I just think the whole process, if you have to have it, worked out as well as I could suspect. So I was diagnosed a little over a year ago, met Dr. Schroff 7 times in the hospital, going through the emergency room, which is not a lot of fun. And little things, I was in the emergency room for, a couple days down in the basement with no windows and stuff, and I hang off the bed because I'm tall, and I saw a guy walk by with a full-size bed. I said, hey, what's that? They said, we have these longer beds. I said, well, what are you doing? So, so part of it is you have to ask. You want to be polite, you want to be nice, but you also have to be your own best advocate. And again, I agree with the lady in row 4 and you about the communication process, because they're doing all this. Sometimes a common sense thing like signage over this foundation, or spots on television, or Dr. Schroff or you others getting interviewed in a piece goes out to the whole community. So Dr. Schroff mentioned that, Camille told me this also, it was in the hospital, and they did exploratory surgery in my stomach, Dr. Liu, and they removed a tumor and rerouted my plumbing. So I've enjoyed, once I got out of the hospital, the past 9 months, basically unfettered, which is a true blessing. So every step of the way, things were, there were mistakes, but overall, the experience has been very good, and I appreciate it. And prayers at night, prayers in the morning, here I am. So I don't know, what else can I tell you? Honey Bunch, what did I miss? Nothing? Because usually when we're in the car, she'll go, by the way, you didn't. Oh, she got notes. I'm in trouble. I'm in trouble at dinner time. So thank you very much.
I've always known he was funny, but that was fantastic, Bill. And I will tell you that the entire time with multiple issues with biliary obstruction and all kinds of other things. He's never lost that sense of humor and just that perspective. And I truly think that's actually what's gotten you here and this far. And I think you're about to have your first wedding anniversary, right? Yeah, absolutely. Yep. It's literally one of my favorite stories. I tell it all the time. Well, thank you so much for sharing your personal story, Bill. Next, I have the privilege of introducing one of our external keynote speakers. And Dr. Kelly Katie Kelly is a professor at the University of California in San Francisco. She serves as the chair of their Data Safety and Monitoring Committee, and she has been the principal investigator on a number of pivotal studies in hepatobiliary cancers. You saw her name up on a number of slides already, including the Keynote 966 data, the Gemcis-Pembro data. She is incredibly prolific. She serves on the Scientific and Medical Advisory Board with me at the Cholangiocarcinoma Foundation, very active with the International Liver and Cancer Association, and on the NCI Hepatobiliary Task Force as well. But much more personally, she is just an incredibly not just prolific investigator, but thoughtful investigator. She is probably one of the best clinicians and scientific minds I've ever had the privilege of knowing. She is so quiet, but when her mouth opens, there is always brilliance that pours out of it. So it is my true honor to introduce her to speak.
Well, first off, I want to thank Rashna for that beautiful personal introduction, and the Cholangiocarcinoma Foundation and University of Arizona for this beautiful venue and hosting all of us speakers and all of you patients today. And also, I just also want to start by echoing what has been said earlier, that I think while cholangiocarcinoma and biliary tract cancers in general, liver cancers in general, can be a very difficult place to be, most of all as a patient, but also as a doctor and also as an advocate, because it's hard. It is also an incredibly special place to be because I feel like it's a very unique place in medicine where we have such true multidisciplinary and multi-personal interactions, both amongst different types of doctors, different types of providers. We have nurses, nurse practitioners, pharmacists, and then patients, family members, advocates, always in the same room, on the same page, in the same conversations, largely really coalesced and catalyzed by Cholangiocarcinoma Foundation, which is truly unique, at least in my experience in oncology. And so I think that's what really pulls us all together and helps us through the hard times, and also has coalesced so much progress in the past decade alone, and especially I feel like the progress is sort of a slow start and now is really escalating onto an exponential curve. So with that, I'm, again, so grateful to be here today and really inspired to see these regional symposiums. This is my first one, and I hope of many. We are committed now to doing one at UCSF in San Francisco, where I'm from, so I'm really excited to see how this one's working to try to emulate many aspects of it for our agenda in the future. And if anyone's in San Francisco on May 15th, please come. So with that, I will introduce my talk. It's titled Combining Chemotherapy and Immunotherapy to Improve Outcomes in First-Line Cholangiocarcinoma. And this will be, in some ways, a synthesis of some of the things Dr. Arshad and Dr. Scott have already introduced. And I'll try to go quickly over things that have already been covered, but perhaps take a bird's eye view, and because I always could use a little repetition myself, so hopefully it'll be helpful too to see some things twice. So here are my disclosures. These are a lot of the clinical trial companies that are invested in cholangiocarcinoma these days that are running clinical trials. So that explains all the names on this page, are clinical trial sponsors. So I'd like to start with a background and biologic rationale summary for why we're combining chemotherapy with immunotherapy these days in cholangiocarcinoma, and then focus on some of the outcomes we've seen both in early phase trials and in phase 3 trials. And really, importantly, focus on some of the key subgroup and correlative analyses, and then conclude with future directions. So again, repetition is sort of the cornerstone of memory, at least for me. I think we've already heard today that cholangiocarcinomas and biliary tract cancers in general are uncommon tumors, but unfortunately they are rising in incidence worldwide. They are very heterogeneous, including by anatomy. Here we can see that we call tumors that start in the intrahepatic bile ducts intrahepatic cholangiocarcinomas, or ICC is a convenient acronym. Tumors that start really where the bile ducts enter the liver are called perihilar bile ducts, or sometimes shortened just hilar cholangiocarcinoma. And they have an eponym called Klatskin cholangiocarcinoma. For those of you who've ever wondered what that means, it's named after Dr. Klatskin years ago, who first discovered this type of cancer, presumably. Gallbladder carcinomas, or GBCs, are part of the family of biliary tract cancers that we often include in our clinical trials. And then those cholangiocarcinomas that start distal or below the cystic duct where the gallbladder enters are called distal bile duct cancers, or distal cholangiocarcinomas. And collectively, just to make things more complicated, we lump the perihilar and distal group as extrahepatics, or ECCs. So these are all the acronyms you might see, which make it complicated as a patient to learn about these. They also make it extremely complicated for our surgeons like Dr. Ryle to operate on tumors like this, and sometimes to really discern where the tumor might have started. Now, beyond the heterogeneous anatomy, these tumors are extremely heterogeneous biologically. They have different mutations, which sometimes track with the anatomy, and they have different risk factors. So anything that causes inflammation can be a risk factor, but there also are autoimmune risk factors, hereditary risk factors, and so far, I'd say probably the majority are still idiopathic, a fancy word for meaning we don't quite understand yet why people get most cases of bile duct or cholangiocarcinoma cancers. So we talked a little bit about chemotherapy already. The backbone to chemotherapy drugs are gemcitabine and cisplatin, based on a pivotal study called ABC02 back in 2010, led by the Cholangiocarcinoma Foundation's own Chief Medical Officer, Dr. Juan Valle. And this study showed that adding the cisplatin to standard gemcitabine improved outcomes. Like Dr. Scott said, we can put our finger between those two curves and see that the top curve has better outcomes. There have been several studies, including this one shown here in the next slide, a study by Dr. Schroff, which look at trying to improve outcomes with these two chemo drugs by adding a third chemo drug. So one from Japan added a fluoropyrimidine drug called S1, and this was actually a positive study, but only conducted in a small number of centers in Japan, only about 250 patients. And while it did show an improvement in overall survival that was significant with the third drug added, it was a rather modest benefit, and there was a lot higher rate of toxicity, diarrhea, stomatitis, mouth sores, and rash for the three-drug combination. And so outside of Japan, this combination has not moved forward due to this risk-benefit ratio not panning out. Now here's another really important study led by Dr. Schroff through the through the NCTN National Clinical Trial Network in the United States. that took the same idea of combining the gemcitabine cisplatin backbone with a third drug called nab-paclitaxel, based on data from phase 2 trials that showed a higher response rate when you add the third drug. But unfortunately, in the phase 3 setting, overall, there wasn't a significant difference in survival, though the response rate was higher. And there was a somewhat higher rate of grade 3 adverse events, showing that, again, while we can make some progress on some of the endpoints like shrinkage rate, it comes at a cost and is not a perfect solution yet. So where this left us is that the first-line 2-drug gemcitabine cisplatin chemotherapy does improve survival, but is certainly not aspirational. The median, meaning if you have 1,000 people, that 500th person will land around 12 months, is by nowhere near where we want to be, and only a subset of patients have major shrinkage. Adding a third chemo drug can help, but it has toxicity, and it hasn't been a huge home run yet. And overall, the duration of response for most people is not as long as we want it to be. So this brings us to one of the questions of why, and how can we leverage the immune system to do better? So when we look at cholangiocarcinomas in particular and biliary tract cancers in general, we see that most of them actually don't have a lot of immune cells, a lot of T cells, a lot of other effector immune cells that do the jobs of our immune system. Most of our cancers in the biliary tract don't have those cells around. And in fact, only about 10% have an immunogenic microenvironment with cells that are really poised to do the work of the immune system. And so that's what here, this little I2 group shows all the dark brown staining. These are stains for immune cells, and these are the class that actually do have a lot of immune cells present, but only accounts for about 10% of patients. I1, I3, and I4 are pretty sparse and barren and what we call cold when it comes to immune system. So that explains why, on this next slide I'll show you, when we use immune checkpoint inhibitors alone in cholangiocarcinomas and biliary tract cancers, they don't work very well. There's probably because there's not a lot of immune cells floating around to do the job. When an antibody comes in to wake them up, they're just not there. And so we know from a study called Keynote 158 that if you give pembrolizumab, the immune checkpoint inhibitor, by itself to people with biliary tract cancers, only about 5.8% of people, so less than 6%, will have major shrinkage. Those that do, it can last for a long time, but the majority of people just don't, the drug doesn't work. That said, these immune checkpoint inhibitors can work for a long time in that less than 6% of patients that do respond, and they're quite well tolerated. Only a small proportion of patients have immune-related side effects. So putting these data together, this begs the question of, could we combine chemotherapy with immune checkpoint inhibitors as that third agent to hopefully help chemotherapy work better without the toxicity of a third chemo drug and help immunotherapy work better? So why might they work better together? Chemotherapy can provoke or prompt an immune response in a variety of ways. We know this from a lot of different tumor types. So sometimes if you kill tumor cells, you can release pro-inflammatory cytokines, meaning the cells will prompt a flurry of these hormones around the tumor that then tell immune cells, hey, come look what's going on, and then the immune cells get there and they can start being more activated. Certain types of chemotherapy, including the cisplatin that we use in our backbone, can cause a type of cell death called ferroptosis that's really provocative to the immune system and sort of wakes up those immune cells even better. Sometimes chemotherapy can inhibit the bad immune cells, meaning those immune cells that are damping our response or shutting things down. So that would be a good way that chemo could help immunotherapy work better. And then chemotherapy, when it kills cells, causes cells to release the proteins and all of their innards to the microenvironment around them. And some of those proteins inside cells can be immunogenic. I think Dr. Arshad mentioned this, and Dr. Scott as well, that the antigens inside a tumor can then be recognizable to the immune system once that tumor breaks down. So with those premises comes the rationale for combining chemotherapy with immunotherapy, not just in cholangiocarcinoma, but in other tumor types. And then cisplatin and gemcitabine, the two drugs that we happen to use in cholangiocarcinoma, have particular mechanisms that make them potentially more immunogenic. So based on that rationale for combining, I'll go into some of the data of early phase clinical trial data that helps support the moving forward into phase 3 trials. So when we take phase 1 trials, we usually don't have a control arm, and so it's very hard to interpret for sure how well the combinations work together. So they're usually what we call signal finding, meaning if we see an intriguing response rate, we then move it into a controlled trial so that we have a comparison arm. So here's one of the early studies where we took an immune checkpoint inhibitor, an immunotherapy called nivolumab, and combined it with GemCis. This was an Asian study, and it showed a pretty high response rate. Around 36% of patients had shrinkage. That's more than, say, the 25% that we expect with chemo alone. So this was promising, and encouragingly, it was a very well-tolerated combo. And so that was one of the studies that led to a pretty big phase 2 trial, sort of the next step in, are we on the right track here? This was a study conducted largely in Korea in multiple centers with over 100 patients. Looking at, you can see this is a very complicated diagram, no need to look at all the little boxes, but the point is the investigators in this pretty ambitious study took a lot of different combinations, looked at both the efficacy, how much did the tumor shrink, what were the side effects for all these different permutations of chemotherapy plus different immunotherapies. And then they also did biomarker studies to say what's actually happening in these tumors, and compared it to just the chemo, historical controls of chemo alone. So again, a very, very busy picture here. But what we saw, or what those investigators saw, Dr. O and her team in this multi-center trial, they saw very high response rates, up to 70% for the triplet, which is much higher than we expect with just the chemo alone, and may probably be higher than, well, we'll show what we see in a bigger population, but it was a pretty provocative number. And also very good safety with minimal significant toxicity. And then I think what I find most interesting about these data are looking at the biomarker results, which give us some clues about what's going on with these combinations. The baseline tumor features really weren't helpful in predicting who does and who doesn't respond. They saw some trends for 2 particular mutations in this study as being associated with less likelihood of response. But one thing they saw that I think is provocative is that they saw that in patients whose tumors increase their PD-L1 expression, that's the target for immunotherapy, on treatment, there was a higher chance of immune response and better treatment outcomes. And this really suggests that the treatments are working together, that meaning if you give the combination, you're going to increase the biomarker that predicts response, and reinforces that potentially it's the combination that's doing the work, not individual components. So based on those phase 1 and 2 data that showed provocative response rates, shrinkage rates, and good safety in this biomarker data that suggests maybe something's happening when they're given together. 2 phase 3 trials have now emerged, and you've seen these from Dr. Scott. The Topaz-1 trial was the first, and then the more recent Keynote 966. So I'll start by briefly reviewing those 2 studies and then go into, I think, what are the really interesting directions for the future, which are looking at the correlative biomarker analyses and subgroup analyses from these studies. So as you saw, Topaz-1, just as a reminder, was a study of almost 700 patients that combined the immune checkpoint inhibitor, a PD-L1 inhibitor called durvalumab, with our standard GemCis chemo, and compared it to placebo plus GemCis. People got treatment for 6 months, and then after that, all the chemo stopped, and people got either the immunotherapy alone or placebo alone. So this is the survival curve that you saw earlier that showed that the people who got the durvalumab immunotherapy had a longer median overall survival compared to the patients who got the chemo alone. There was also a longer progression-free survival, meaning a duration of disease control, and a higher shrinkage rate in this combination. Importantly, and this is this DOR is something that matters to me a lot in the clinic, and I think is what matters extremely to patients. DOR stands for duration of response, meaning are these responses what we expect from chemo that last for a while but then stop after about 6 to 7 months? Or are these responses that are actually indicative of our immune system learning the cancer and cloning itself and working for a very long time? And what we see in the purple curve is evidence of the latter, which is that the people who get responses, those responses tend to last a lot longer than just the chemo responses. And that's what we're going for. And again, while of course we wish this number were much, sorry, lost my mouse, here we go. We wish this number were much, much higher. We see a clear separation in the duration of how long these responses last. And that, what we're hoping this means and what we think this means is that the immune system is at play, and it's not just chemo working for a short period of time, it's chemo educating your immune system, and then those T cells working for a long period of time. And again, those are the kind of responses we want. And the x-axis on this graph here are measured in months. And so as you can see in that long, here we go, purple line out to the right, these are ongoing, really durable responses. Quickly on safety, just to reassure, when we looked at the placebo arm versus the immunotherapy arm, both combined with the standard chemo, very similar rates of treatment-related toxicity, no significant increases in serious adverse events or deaths, so that's obviously very important in a phase 3 trial and was very reassuring. When we look at subgroups, Dr. Scott did a nice job of explaining this plot called a forest plot, where the line 1 here indicates sort of equal benefit for each arm, and we can see that to the left of this line that indicates better benefit for the durvalumab arm in this plot layout. We can see all these little dots for key subgroups such as younger age, older age, PD-L1 expression, lack of PD-L1 expression, tumor or race and region, all fall to the left of the line, that indicates statistically that the durvalumab, the immunotherapy arm, performed better. So that's exactly what we want to see. We can use a lumping approach, as Dr. Scott also mentioned, when we see a line like this where pretty much everybody seems to do better by adding the immunotherapy. So also really reassuring. And delving in even more deeply into region and location, we saw generally these benefits were, again, if we parsed out location of tumor and location of patients, and they also fell to the left of the line, indicating benefit. So based on the strength of this data, the FDA approved durvalumab for metastatic biliary tract cancer in 2022, a little over a year ago. And I want to show a couple of cases of real-life patients. Here's a patient of mine who's a 67-year-old gentleman, no hepatitis B or C infection, who had a distal cholangiocarcinoma near the pancreas, had a hepaticojejunostomy and bile duct resection, and didn't have any great molecular targets at the time, so he got adjuvant capecitabine for 6 months and had no evidence of disease by 2021. Unfortunately, in 2022, his CA19-9 started to go up. He started to have a little more abdominal pain, so we got a PET CT scan, which showed little areas of brightness near the surgical margin, but also in some peritoneal implants, including this one is just anterior to the rectum. He was having some GI symptoms, and that proved that he had recurrent metastatic cholangiocarcinoma. We confirmed this with an endoscopic ultrasound EUS biopsy. So unfortunately, he had a recurrence about a year later. So then we started him, at this point, the TOPAZ-1 data had just come out and had been approved, so we started him on Gemcis plus durvalumab, and he tolerated it great. He had a mild rash, that was about it, and had a complete response. So all of the spots of brightness normalized, his CA19-9 normalized, and so after 6 months, maybe a little more than 6 months, we switched him to just the maintenance durvalumab per the TOPAZ-1 regimen. And with that, he did quite well for about 8 months, but unfortunately started to progress again after that period of time just on the maintenance therapy. And so looking ahead to the future, based on his molecular targets, we were actually able to put him on a clinical trial of an ATR inhibitor since he had a tumor ATM mutation. This again harkens to Dr. Arshad's talk, that we're again trying to think ahead for all of our patients based on their mutation profile. So while this wasn't a home run for Topaz, his immune system didn't learn for long enough. It did learn for a while. He had prolonged stable disease just on durvalumab, and now again, while I wish he had stayed in a longer remission, we do have a new treatment for him, and he's on that trial as we speak. Here's another patient who is a 69-year-old patient of mine who I've known for a while now, who's a ballroom dancer, golfer, lots of other hobbies. She developed biliary obstruction as well, had a common bile duct tumor that was pretty extensive, needed to have resection of the tumor and her gallbladder, got adjuvant capecitabine. And then unfortunately, a couple years later, developed recurrent biliary obstruction and had a lot of complications due to recurrent cholangiocarcinoma in the remnant common bile duct. And so she started the first-line Gemcis plus durvalumab Topaz regimen in January of this year, had a lot of infections due to the blockage in her tumor, and needed to be in and out of the hospital with infections like we heard about, and stent changes, and didn't ever need a percutaneous drain, but had a lot of different, like 3 or 4 stents at a time. But has recovered from that after the prolonged antibiotics and stent management. Hearkening to the multidisciplinary nature of this, I'm constantly on texting with our GI team about getting the stents changed whenever needed. And quite encouragingly, this area of tumor that we were seeing last year, this is see these little white circles and sort of hypodense areas. It was a combination of tumor plus infection. Over a prolonged period of the chemo, immunotherapy, stent changes, on and off antibiotics, some breaks in treatment, has significantly shrunk to the point we can really not see it so much anymore. This is a little remnant cystic lesion there. And her stents, the tumor has shrunk enough that her stents have been removed most recently, just 2 weeks ago. And so now she's on the maintenance durvalumab. And again, I don't know how long her immune response will last, but I certainly hope she's one of those people on the durable purple curve where the response keeps going, and time will tell. And these are the arrows just to show her tumor. So that brings me to the next study, which is Keynote 966, which I had the great fortune of being one of many team members in implementing the trial and running it at our site. And our nurse Jennifer, who spoke earlier, is well familiar with a lot of the patients that we enrolled on this trial. This study was very similar to the TOPAZ-1 trial. It randomized patients to either the standard chemo plus a different immune checkpoint inhibitor called pembrolizumab, or the same chemo plus placebo. And this was a very large trial. It's actually the largest trial in the history of biliary tract cancers to date, with over 1,000, specifically 1,069 patients enrolled. And this is a really busy slide, but the key points here is that this study, it was a slightly higher proportion of patients were enrolled in the West, and so in the US and Europe, compared to TOPAZ-1. So it had a slightly lower proportion Asian patients and a higher proportion of non-Asian region. It also had a higher, similar to TOPAZ-1, it was predominantly intrahepatic cholangiocarcinomas. And here we see survival curves showing ongoing survival benefit, both at the 12-month mark and the landmark of 2 years or 24 months. We don't see quite as much separation in the curve visibly, as Dr. Scott pointed out, in part, though, because this trial allowed continuation of chemo. And so the dark purple line on the bottom is not a placebo arm, it's actually chemo plus placebo. So this arm performed better than the arm in TOPAZ, so the comparator arm had some active treatment going on. But despite all that, this over time and with long follow-up, the study showed significant improvement in the median. This was also generally true across key subgroups, region, race and ethnicity, and PD-L1 tumor marker expression status. Extrahepatic and gallbladder patients were a minority of patients in this trial, and they tended towards less discernible benefit, but I think in part that's because of the challenges of obstruction and blockage that often accompany extrahepatic and gallbladder, and it makes it much harder to delve into differences when people have infections and blockage. Response rate, bearing in mind the ongoing chemo in this arm and the fact that it was a central review instead of an investigator review, didn't show a huge difference between the two arms. But back to what I was saying is my favorite metric, which is DOR, duration of response. We see that the pembrolizumab, the immunotherapy arm on the green, has a longer duration, meaning these responses kept going a lot longer, and we see a flattening of the curve, meaning people just stayed responding in a higher proportion of patients compared to the chemo alone. And again, reinforcing that of the people who respond, a subset of them are getting their own immune systems educated and learning the cancer to do the job for the long run, not just for the chemo doing it for a short run. Like TOPAZ, side effects were pretty similar between the chemo arm and the chemo plus pembrolizumab arm, again, quite reassuringly similar, in fact. Putting all of that together, quite recently on Halloween this year, actually, the FDA approved the Keynote 966 regimen as another first-line option in addition to TOPAZ-1. And so I'll pause there and just say, I think that these two options both validate the principle that adding immune checkpoint inhibitors helps a subset of patients. It doesn't help all patients as much as we want. I think they're both equivalent. I think the data are quite similar between the two, and it's extremely helpful to have two different options for a variety of reasons, and not least of which is in certain parts of the world, only one of these drugs might be available, and there's also potentially cost differentials for an institution depending on the contracts that an institution may have with the drug provider. So this is a good thing for the field to have two choices. Now, delving into where we want to go in the future with these data, the TOPAZ-1 trial, being ahead of Keynote 966, has already presented its biomarker analyses. And the big picture of this is it's great that some people are getting these long responses. It's fantastic when we see them, but obviously not all are. And we want to figure out who are the people that we need to try a different strategy on, either combining a third agent or a fourth agent if needed, or trying a totally different tack if this one isn't working. And so part of that, and who are the people who do fantastic with this, that we should just go straight to this type of regimen. And so really delving into those details requires us to take all of these samples and do mutation profiling and figure out who responds and who doesn't. So the Topaz study had almost 700 patients, and about the majority of them, they were able to do immune profiling of PD-L1 status, as well as mutation profiling using a panel called Foundation Medicine, or FMI in this case. And they called this subgroup of patients that had all these biomarkers analysis the biomarker evaluable population, or BEP. And so among that biomarker evaluable patient population, these are the most common mutations that were present. You don't need to read them, but they include things like our well-known FGF, this is FGF amplification, here's FGFR2 fusion, is only a minority, 3.4% of patients actually, and then all in between here we see IDH1. So the most prevalent mutations are represented in this chart and show the proportion of patients in the Topaz 1 trial who had these mutations. And then here's a slide that Dr. Scott showed as well. And I think, well, as Dr. Scott said, we see generally most of these dots fall to the left of this line, which indicates that most subgroups benefited from the addition of durvalumab. But I want to draw our attention to a couple groups that didn't. We see here certain mutations with the alteration, and they're small numbers, so that's why the dots are so small, didn't have quite as much benefit or no clear-cut benefit. So CDKN2A and B deletions didn't show quite as much differential benefit. Just, again, this is hypothesis generating data, not confirmatory, because these are just small subgroups. Here we see ARID1A, similar to the phase 2 trial I showed earlier, also fall towards favoring just the chemo for some reason. And then we see ERBB2, which is the gene for HER2 protein, also is an outlier where patients had lower survival with the addition of chemo, telling us something's off with these groups. Again, just a hypothesis, not proof. When we look, so this chart here is looking at just how long people lived on the combination. What was their survival and was it different? When we look into the weeds of response rate, we can see kind of a similar story for a couple of the mutations. Here we see that, so in this picture, it's a little complicated, but the purple bars are patients who got the durvalumab immunotherapy with chemo. The yellow are those who got placebo. And the solid ones are patients who don't have a mutation. And the striped ones are patients who do have a mutation. So here we see a provocative and a little bit worrisome signal where in patients with IDH1 mutations, again, small numbers of patients, but the response rate was higher in patients with mutation who got chemo and lower when they got the immunotherapy. Again, super small numbers, but kind of fits some of the data from the earlier trials. And likewise, patients with this HER2 amplification didn't show a clear-cut difference when you added immunotherapy, and they had the worst survival. So nothing proof here, but just driving us to say, where can we make improvements and help other patients do better? So the conclusions from these data are, just to step back again, adding either an anti-PD-1 or an anti-PD-L1 immune checkpoint inhibitor antibody, a type of immunotherapy, and specifically the drugs we have data for are pembrolizumab and durvalumab, adding either of those drugs to our standard chemo overall improves survival in first-line advanced biliary tract cancers. Overall, the improvements are modest when we look at the medians, like the patient number 500 in a splay of 1,000, for example, but a subset of patients have really prolonged responses. So the group of patients who responds can have a dramatic life-altering benefit. This benefit, getting into the weeds, appears to hold true whether we continue the gem after 6 months or not, so we can make an individual decision based on our patient's needs. And mostly the improvement is consistent across geographic and molecular subgroups with, as I showed, hypothesis-generating data suggesting maybe some mutations don't do quite as well as others that we need to scrutinize more and come up with more research for. That's ERBB2 or HER2, ARID1A, IDH1 are a couple that stand out. We also see the gallbladder subgroup maybe has a little less differential benefit and might need another strategy such as a chemo triplet for that based on Dr. Schroff's data. So again, we're learning from these data. And fundamentally, another point to add here separately is that adding the immunotherapy shows acceptable safety. So thankfully, we're not seeing any concerns about worse toxicity. And based on the strength of all this data, we have these regulatory approvals, and we have the choice of using either Gemcis durvalumab or Gemcis pembrolizumab in the US and in many other countries now. So where do we want to go? This is my last slide. So first, we want to try to refine which patients we're treating and which patients we look for new strategies for. I already mentioned the gallbladder and extrahepatic and certain mutations might need additional preclinical studies to figure out what's going on and whether they might have a different immune background. And this is a really key point, I think, for Cholangiocarcinoma Foundation to help us with, and patient advocates and all of us investigators to speak up, that we really need these data from Keynote 966 to be able to combine with Topaz-1, or at least analyze in parallel, so that we can see, do these trends hold up? Are these little hypotheses in small numbers of patients from Topaz reproduced or refuted by the larger Keynote 966 data, recalling that Keynote 966 is a much bigger study, over 1,000 patients. So we'll get a lot more confidence in our signals and whether we're right about some of these trends or not. We don't really know for sure what component is doing what amount of work with a 3-drug regimen, but I think, like I've said many times, that duration of response curve showing the long duration of responses, plus the phase 2 biomarker data showing the upregulation of PD-L1 with the chemo plus immunotherapy triplets, suggests that there's a synergy going on and that they're doing something together, not individually. And then, what is our new standard? Is GEM-CIS plus immune checkpoint inhibitor the new standard therapy as a lumping strategy? I'd say yes, emphatically, but with that's the glasses half full. Definitely this has changed practice. The glasses has room to go is that only a subset of patients experience the benefit that we want, and we need to come up with new strategies, so new combinations, particularly for maybe those outlier mutations or gallbladder, and potentially take some of this knowledge to earlier stages of disease, whether adjuvant or neoadjuvant. So with that, I'll close, and thank you all for your attention. Thank you again, CCF and University of Arizona, Dr. Schroff, for the invitation, and to my team. This is our UCSF hepatobiliary team. You'll see Jen Wild here, and we couldn't do this without our team. Thank you.
As always, an incredibly comprehensive, insightful, and very easy to follow talk. Thank you so much, Dr. Kelly. I want to be mindful of the fact that it is lunchtime and people are probably hungry. So we have time for maybe one question. Dr. Kelly hopefully won't mind if there's other questions maybe during the lunch break, but one question? Okay.
Yeah, agree. It's such a fantastic talk. So provocative too. So I have many questions, but one is, I wonder if you have compared the subgroup of patients with long-term benefits to other patients without, but within all the immunotherapy treatment arm.
That's a great question. And some of the initial hypotheses, like patients with tumor PD-L1 expression, are not bearing out as the key differentiator. There's certain mutations that tend to do better, like BRCA1 and 2 mutations have better response rate and better time to event or longer benefit. But I think that's the exact kind of question that we need to study with additional follow-up, bearing in mind that both of these data sets are pretty new. And also they're very small when we start winnowing out certain subgroups. So I think pooled analysis and additional molecular analyses are needed, because the low-hanging fruit hasn't shown a clear-cut defining feature.
All right. Thank you all so much for your attention. We are going to have our lunch break now. 12:45 to 1:30, I believe, is when we reconvene. So until 1:30, and then we'll gather everybody back for another one of our fantastic external speakers. Thank you all so much.